We'll make it work. So I'm Kim Prather. I'm a professor at University of California, San Diego. And I have the distinct pleasure of hosting or helping host this meeting along with Joaquin Beltran from Speak Up America, which you'll meet him in a little while. And basically we're going to cover quite a bit of ground in 2 hours. So everybody should have their seatbelts on. But one of the questions, and I just want to sort of give a little bit of background about how did we get here, is, I was getting more and more, my kids are grown up, they're fully vaccinated, but I was just really worried as I watched schools reopening. I wasn't hearing things that I would have liked to hear about measures to clean the air. I'm an aerosol scientist, and so we've been squawking for a year and a half saying it's airborne. It is airborne, mostly. And so there's huge challenges to actually trying to open schools. Now with Delta, it makes it even more challenging. So what we want to do today is cover ground from the science, how you can protect yourselves, how you can check if your schools are doing kind of it enough. I'll talk about an example where I helped San Diego Unified schools open last spring, again, pre-Delta. And then we'll have a panel discussion, just probably with many of the questions and concerns that a lot of you are thinking about. There's just been, I have to say that it has been an overwhelming amount of support. Everybody who's on this call dropped what they were doing to do this. Nobody said no, and they said, well, a couple people did, but I talked them back into it because they were busy, but they literally changed schedules to be here. But again, I think I feel better. It's a lot of work. It's been, 5 days rush, kind of crazy, but as I say, I think we have a good, you'll learn a lot today. So basically, as I say, we'll cover, all the way through these different topics. The last thing I just want to say to set the stage is with one of the things people say, oh, do we need masks? Do we need to clean the air? Do we need to scrub the surfaces? Do we still need to wash our hands? And the answer is yes. With Delta especially, we have to have what has been referred to, this a picture that was adapted by Ian McKay, called the Swiss cheese model. Each layer has its own little, it's not perfect, right? But when you stack it together, you get a block. And that is what we need to protect us from Delta, especially in schools. And so today you'll hear from various people about all the different measures that are being used and why all of these matter and how you will know how to implement them. And so at this point, I would like to hand it off to Dr. Denise DeWald, who is going to tell us a little bit more about concerns or things we should be thinking about the status of schools right now. She'll give a little bit of a background and help me finish off this introduction. Denise?
Yes, thank you. Thank you, Kim. Oh, I'm trying to share my screen. Okay. Okay, thank you, Kim. So I am a pediatrician and I am here to advocate on behalf of all the children who may need medical care in the next few months. So I'm going to talk about the capacity of the pediatric hospital system because we've gotten a lot of reassurances, most children don't get sick, but we're now seeing children getting sick. And so we're back to talking about flattening the curve. So Delta is different. Delta is sickening children, and it is also as contagious as chickenpox. And the problem is that the pediatric hospital system isn't able to absorb a surge as well as the adult system because there are far fewer pediatric beds, and pediatric hospitals provide very specialized care to children that adult hospitals can't provide for. And so there, as of 2018, there were 27,500 inpatient pediatric beds and 5,400 pediatric ICU or PICU beds. And usually pediatric hospitals are about 80% full with a little bit of routine surge capacity for taking care of like RSV and flu, but 80% of these beds are taken up by children with cancer, asthma, diabetes, sickle cell disease, among many others. So all treatable conditions that are potentially life-threatening. So our wiggle room for taking care of children with COVID is really only about 5,500 hospitalized children and 1,100 children in the ICU. before we start impacting the care of all of these medically vulnerable children that we need to take care of. And so, like pediatric cancer patients, 80% of pediatric cancer patients are cured or become long-term survivors. And treatment interruptions can really harm their prognosis. So they become untreatable and die from an otherwise treatable cancer. And they're also very susceptible to getting sick with COVID and dying from COVID. So we need to protect them. So let's look at the numbers. We've got about 34 million school children in the US who are susceptible to COVID. And based on the numbers from last year, we could expect about a 1% of them to need to be hospitalized if they're unvaccinated and catch COVID. And about 1/3 of those children would need pediatric ICU care. And so with Delta being as contagious as chickenpox, if because of inadequate mitigation, we end up with a scenario where like 50% of school children get infected over the span of 30 days, and 1% are hospitalized and they stay in the hospital for 2.5 days, we would need 14,000 pediatric hospital beds and 4,700 PICU beds. But we just said our wiggle room is 5,500 inpatient pediatric beds and 1,100 PICU beds. So we will overwhelm the capacity of the system to take care of the sick children. And if we are off by just a little bit, if many more children are hospitalized or they stay longer, there will be many, many children who will go without medical care. And how do you triage children in a crisis situation? Most of the children who enter a pediatric hospital can be expected to live long and full lives. And so the children are counting on us to get this right. Okay, thank you.
Okay, well, that sets the stage for the background, and I thank you for that. And now I will go back to sort of laying down the, get this, why is it not? Okay, hold on, sorry, I'm gonna go back. Be quick. Sorry about this, okay. All right, so I will now talk about what we know about how this virus is transmitted. I will just say that I've spent a lot of time, as well as many others, about just basically saying since the beginning that this virus is spread in tiny little aerosols. And so now I want to bring everybody up to speed about what we know about the airborne transmission of this virus. So this is a figure that Lindsay Marr, actually, who speaks after me, her child made, and so it's gotten lots of use, but it lays out very well sort of the situation that we're dealing with and how this virus is spread. And the main way it's spread is in tiny little aerosols. So when you don't have to cough, you don't have to sneeze, and many people that are spreading this disease don't have any symptoms. So they don't even know they're sick. So they're out, talking, yelling, singing. And when you do that, you produce thousands of aerosols, not very many of these big droplets. And these aerosols behave much like cigarette smoke. They just will float in the room and they can fill a room. Think about being in the room with a cigarette smoker, and over time, how it can build up over time if you don't have good enough ventilation. This is why ventilation is so important. This is why indoors is the place where most of the spread happens. So basically aerosols come out, also a few little droplets, but the difference is that the aerosols float and the droplets drop. And so that's where the 6 feet, this magical 6 feet came in, was that people were really fixated in the medical community, mostly on droplets, but that's not what is driving this disease. And so basically still at close range, distance still matters because aerosols are still really close, concentrated up close. So short range inhalation is most likely the dominant pathway. Droplets, they will only get you if they, splatter right on your nose or your mouth or your eyes. And there aren't very many. And then over time, you can see that there's this, what we call long range aerosol inhalation, which is in medical terms has always been called, quote, airborne, but distance doesn't matter. There's papers written about this. All evidence that we have right now points to aerosol transmission. We don't have any evidence for droplets. And we have, there's sort of studies coming out about surfaces. It's still really important to clean surfaces, but not spend so much time and so much money. One key thing to school reopening is rather than worrying about, we got to clean where the virus is, and that is the air. And today we'll spend quite a bit of time talking about that. What makes this extra challenging has already been mentioned. It's nearly as contagious as chickenpox. People kept saying, it's not airborne because it's not that contagious. Well, guess what? Delta is. And there's 1,000 times the viral load. So you heard of this 15-minute recommendation by CDC. If you believe that that's kind of the limit of how much you should be, because longer you're with somebody in a room, the more chance you'll inhale it and get infected. If you believe the 15-minute magical number, now if you take 1,000 times the viral load, then in basically in 1 second, you could inhale that same amount of virus. So it's gone from 15 minutes down to 1 second that you're exposed to the same amount of virus. Okay, so the reason we've been pushing so hard and the reason schools need to acknowledge is that once we acknowledge it's airborne, the good news is it's fixable. We can clean the air. We've been using technologies to clean the air for decades. It's very, very possible, and we can sort of slow down all the effort we put into cleaning, scrubbing. Don't spray chemicals in the air. That just makes worse air. And we can start, thinking about other, basically looking at it from the perspective of the air. So CDC is now on board, says the chance of being infected is very, very low from surfaces. It's still possible. There's very strong statements that came out finally in about April that we really need to be focusing on airborne transmission. So the last little bit that I want to point out is, once we understand how it's transmitted, it's essential, then we can actually figure out where are the riskiest places. What are the riskiest activities that are leading to this spread? So the bottom line, as I've already said, is indoors is far higher risk than outdoors. And so that's just because of dilution. Outdoors, it just gets diluted, so you can't inhale as much as quickly. Not wearing masks indoors is not a good idea, especially with Delta. And you'll hear from Lindsay Marr after this, what kind of masks should we be thinking about. You also, if you really have to be indoors without masks, I'm thinking lunch, you really don't want to be talking, because just talking produces more, yelling even more, singing even more, exerting yourself in sports even more. So we really have to be thinking about these things. The other thing is, sometimes we're so fixated on the classroom that we forget there's other places that kids could get infected, like cars and buses, smaller confined spaces, elevators, bathrooms. A big missing thing, if you learn nothing but this today, is that the person that's infectious doesn't have to be in the room at the same time as you. They could have been there before you, because once it's in aerosols, it can exist in the air for hours. And so there is evidence that people have walked into a bathroom, which are notoriously poorly ventilated, and they become infected. So we really need to just become more aware. And you'll hear more about eating lunch. But basically, this just shows risk. What's the safest things to do? Be quiet and wear face coverings, all the way down to the riskiest is in a bar, people yelling with no masks. And so again, we can think about things in a much more sensible way and protect ourselves if we understand how we're catching it. So the last thing I want to point out is just this one key point, because today we're going to talk a lot about masks and whether there should be universal masks, whether everybody should be wearing masks, even the vaccinated. This just shows how much virus is in someone that's infected. For somebody who's had a breakthrough, so they're fully vaccinated and they catch it, versus somebody that's unvaccinated and gets infected. And you can see the viral load is as high for the vaccinated person, but for a shorter time period, but still as high. So this is why I think you'll hear a lot of us saying that it's really important, for many reasons, that everybody right now, to get us through Delta and to stop this thing, we should all be wearing masks. And so at this point, speaking of masks, I'm going to hand it off to Lindsay Marr, who was gracious enough to change her schedule to be here, because she was the main one that I wanted explaining masks, because I know she's done it a bunch of times and she will do it again right now. So Lindsay.
Thanks, Kim, for the introduction. I am a parent of a 10-year-old and a 13-year-old. So the 10-year-old's unvaccinated. They started school on Thursday. I was worried, and I'm worried. And so I'm here to talk about masks for kids. I know masks have been somewhat controversial, but let me briefly explain that masks work not by sieving, but by filtration. Early on, I saw a photo somewhere on social media showing, oh, well, masks don't work. Look, this bird can go right through, but that's not how a mask works. A mask has multiple layers. You have to shrink yourself down to the size of individual fibers. And now, if I'm the road runner, even if I'm a very small road runner and I have to get through this fast, this is a big obstacle course. And I'm going to end up crashing into one of those fibers or one of those fence wires. There's lots of misinformation out there about masks. It's saying that they're harmful for children or they don't work. The fact is that they do work. You can't get around the physics of it. Masks have been shown to work in schools. This was a large study involving over 500,000 households. And the way to read this is that things below 1 on the odds ratio, y-axis, indicate that there's reduced risk. Things above 1 indicate that there's increased risk of having COVID-like symptoms. So this was looking at schools and different interventions that they made. The more interventions, the better. And you can see that masking did help reduce the risk of having COVID-like symptoms, especially if teachers were masked. Now, this was before people were vaccinated. So Delta, as Dr. Prather explained, is much more contagious and requires better masks. Here are the priorities when choosing a mask. 1 is comfort. If your kid won't wear it, then it's not helping at all. 2nd is fit. Any leaks around the sides are like having a hole in your mask, and aerosols carrying the virus can get right through. And the 3rd is filtration. These are all important, but I've put them in order. Now, on the far left-hand side, I've shown a couple of options. One is CDC's study showing that double masking does help protect the wearer. The best way to do that is to wear a surgical mask, which acts as a very good filter, but doesn't fit well, underneath a tight-fitting cloth mask, which helps hold down the edges of that surgical mask, giving you both fit and filtration. There's been some discussion about N95s for kids. N95s are not made to fit kids. They do not come in kid sizes, so I do not recommend N95s for kids. There are some alternatives, the Chinese and Korean versions, which are a KN95 and a KF94. They have similar filtration capabilities, and they are designed to fit closely to the face and to minimize leaks. Some of those are being made in children's sizes now. And then finally, there are masks, cloth masks that include a built-in layer of filter material that is very high performing. Some of these are filter out more than 99% of particles, and those are also can be very effective if they fit well. There is a new ASTM standard for barrier face coverings, and there's 2 different levels, level 1 and 2. What the manufacturer has to do is to have their mask tested for filtration efficiency. They will report that number. You should look for a higher filtration efficiency. They will also report the breathability, and there you're looking for a more breathable mask, and they can also describe something about the fit. And we have created a document shown there. There's a link at the bottom, tiny URL, BT Kids Masks, which contains more information like this and a list of masks that we have identified that fall into this category on the right, where they're cloth masks with built-in good quality filters. And we also list those that have undergone the ASTM certification, gone through that process, or report that information. We have not compiled a list of KN95 and KF94s for kids. Those appear to be widely available, but you do need to watch out for counterfeit ones that are do not perform as well. I wish I could give you some reassurances about which ones are genuine or not. I know that NIOSH has a list of that for adults. I'm not sure what the status is for kids. Thank you very much.
Okay, so now we're going to kick into the other way you can filter the air, and Dr. Rich Corsi will talk about whether it is what are the ways that we could actually be cleaning, what with the ways we should be cleaning the air right now. So I'm going to hand it off to Rich.
Thank you, Kim. And I want to thank Kim also for being a graduate of the College of Engineering at UC Davis. So am I sharing now? Am I on?
Not now, it's coming on. There it is. You
All
just
right.
have to go to presentation.
Great. Great. So the question I was given was, are effective measures possible by fall? And I'll just say yes, for some interventions they are, and for others they are not. They're just too disruptive and take too long and too much money at this point if they haven't been started. So I'm not going to get into detail on this, but schools are critical environments. We've already heard that. I just wanted to point out that children spend about 20% of their time inside of school buildings when they're school age. That's more than all other environments combined, indoor and outdoors, except for their home. And schools are such an important enterprise. About 20% of the US population spends 6 or more hours in schools every day, every school day, every weekday. And study after study, as has been pointed out, shows that indoor air quality and ventilation in schools is important and also impact local communities. I'll say as a gross generalization that schools were pretty unhealthy before pandemics. I've studied a lot of schools in Texas. This is a plot of the air exchange rates in schools. The dotted lines are where ASHRAE 62.1 2019, the standard is for high school for these particular high school classrooms, 47 classrooms. You can see in permanent classrooms, we're often 1/2 to 1/3 of the ASHRAE standard before the pandemics. And when that happens, and you survey teachers and staff, you hear a lot about them being bothered by odors, students complaining of odors, students saying that the odors affect their work. That's a sure sign that something's wrong. All right, so our goal should be to reduce risk by reducing inhaled dose. At least that's what I'm going to talk about. Without getting into all the details and what inhalation dose is, there are 3 things that we can control: the amount of time we spend in an environment, our breathing rates in an environment. The higher our respiratory minute volume, the greater the intake of virus-laden aerosols, and then the concentration or levels of aerosol particles per liter of air, say. All right, so I'm going to focus on that. And that concentration, if you just use a simple steady state sort of maximum concentration value, is a function of a lot of things, right? I'm going to look at the concentration of particles in number per liter. And to reduce that concentration of particles, we can wear a mask, as Lindsay just said, because we're interested in the concentration in our breathing zone inside the mask. We can lower the emissions by testing and mandatory masks, which reduce the emissions from the infector. Increase ventilation, this term lambda here in the denominator. Use proven particle controls, this term in the denominator, or make use of volume of the space, right? And so I'm going to focus on increased ventilation and increased filtration in my next couple of slides. So for ventilation, what we're trying to do is increase this value of lambda, the air exchange rate, as much as possible, which drops the concentration in room air, whether that's a teacher's room or whether it's a classroom, a teacher's break room, et cetera. I do want to say that the best thing we can do, if possible, is to have as many activities outdoors as possible. Increase benches, stools brought outdoors, whiteboards, chalkboards. I hear a lot of complaints about this idea, and I just want to say that you can't do it all the time, but whenever you can be outdoors, meet outdoors, have class meetings outdoors if possible. Mechanical ventilation, there's lots of different types, including unit ventilators and centralized systems. It's too late to make significant system upgrades at this point. Really needed to start that in spring of 2020, and too much of America dragged its feet, and that didn't happen. So, but we can in systems that in schools that have existing HVAC systems that are centralized. We should open outdoor air dampers as much as we can, and definitely disable demand control ventilation. We want to continue to ventilate classrooms when students are out of them for recess or at lunch period before they come back. So those things can be done. And blue here means things that can be done now and quickly. Natural ventilation, open windows and control the flow with fans in or out or both. The design of that is important. You don't want to have 2 windows that are right next to each other that are open, where air is flowing in one and out the other, and you get short circuiting. So there's some design of it. For schools that have operable windows, that can be done right now. For filtration, we're dealing with this term here, which is a clean air delivery rate, the single pass removal efficiency for particles of size I times the volumetric flow rate through the device. divided by the volume of the space. And this entire term here has the same units as air exchange rate per hour, for example. So sometimes people combine these two and talk about an equivalent ventilation rate. What we should be doing here is upgrading system filters, as you see here, upgrade from MERV 8 to MERV 13 filters at Portland State University. Use the highest MERV possible to increase the single pass removal efficiency. It's not possible to do this by the start of the school year if you haven't already procured MERV 13 filters or better filters. And it's a disruptive activity. You need to shut down the system while you're doing it. So it needs to be done at night and weekends. It's probably too late to do that before the school year for schools that haven't opened, but it is possible to do it during the school year if done at the right time. And then do regular inspections for gaps and bypasses. You can see here at one school we tested in Texas, where pretty much a lot of flow doesn't go through the filter at all. And regular inspections for that kind of thing are really important now. Lastly, portable HEPA air cleaners can be very effective. Same part of the equation here. The clean air delivery rate is this top term, eta times Q, and that's what you will normally find when you try to purchase one of these units. To convert to an equivalent air exchange rate, all you do is take the clean air delivery rate, divide by the volume, multiply by 60 to convert from minutes to hours. And I just show you an example here for a relatively, well, it's a smaller size classroom, but not unreasonable classroom with a clean air delivery rate, with a device with a clean air delivery rate of 300 cubic feet per minute. That gives you sort of a jolt of an additional 3.8 per hour equivalent ventilation. So if we're starting with 2 per hour, and a lot of classrooms I've tested in Texas start with a lot lower than that, but if we start at 2 air changes per hour, and we use the clean air delivery rate that I just showed you, a HEPA-based system with that clean air delivery rate, for that classroom, we go from 2 to 5.8 per hour, which leads to a 66% reduction in virus-laden particle concentrations in air. If you add that to relatively mediocre masks being worn by everybody that give you an effective 75% reduction in inhaled dose, we get to 92% reduction in inhaled dose just from everybody wearing relatively mediocre masks and having a good portable HEPA air cleaner in the classroom. That's pretty good. And that is possible by early fall term. And it's relatively cheap. I've worked out the costs of this for one good portable air cleaner in a classroom of 25 students. The cost works out, capital cost, recurring filter replacement costs, electricity costs of about $10 per student per year. That's 2 venti Americanos per student per year. And I want to remind everybody that it costs us about $15,000 per year to educate one student in the United States. So I think $10 is a pretty darn good investment in the future. If you can't procure portable HEPA air cleaners fast enough, or you don't have the money, you can roll your own, and building your own can be pretty effective. They can be built quickly. This can be done quickly before school starts for many schools or early in the school year. And I know that the team that's up next is going to discuss these in more detail, so I'll end there. Thank you very much.
Great. So we've got the team. It is a team that is, we have the team. This is the A team for building these things. And so looks like, I think, David, you're starting us off, right? Okay.
Yep,
great.
I'm up.
Okay.
So my name is David Elfstrom. I'm an engineer in the province of Ontario, Canada. And ventilation is a very important factor. It's the main difference between indoors and outdoors during this pandemic. So a quick definition of ventilation. We've already talked about it. Here's a quick definition: supplying clean outdoor air to the space and removing stale indoor air. There's 3 main types of ventilation for classrooms. Natural, basically through windows. It is inherently unreliable, and there's many cases where the windows just can't open very far for other reasons of safety and security. Second, common in around 1960s type construction, partial mechanical ventilation. This is a classroom with an exhaust fan in it, usually close to where the blackboard is, and it exhausts some of the stale air, but the air that comes in either comes from other classrooms and other locations, or it comes in through cracks and open windows. So it's coming in and it's not filtered. The third type is a mechanical ventilation system. It uses fans in a system to provide outdoor air, filter it, and also remove stale air. So when there's an outbreak, if it's a food outbreak in a restaurant, or a water supply outbreak, the first thing you do is send engineers in to have a look, or not for food perhaps, but for water outbreak, it would be send engineers in to have a look at it. We need to be doing that when there is an outbreak in a congregated setting like this for a classroom, to check the ventilation systems. One way that we can do that, even before there's an outbreak, is by measuring CO2. And for that, Dr. Popendick.
You're
Okay,
muted.
thank you. Can you hear me now?
Hi, Dustin. Yeah, we got you. You're good to go.
Okay. My screen is not showing. All right, there. Okay, thank you, David. Before I start, I want to note that the methods presented today are not a recommendation or endorsement from my employer. So where does CO2 come from in a classroom? Your lungs exchange oxygen in air with carbon dioxide. And importantly, the amount of carbon dioxide that we emit depends on our age, activity, and our size. The air we breathe in is about 0.04% carbon dioxide, and the air we breathe out is about 4% carbon dioxide. Given this relatively high concentration compared to other chemicals and emissions from people, carbon dioxide is a good proxy for emissions from humans. In fact, we can use it to determine the fraction of air you breathe in that has been in other people's lungs. For instance, if the indoor carbon dioxide concentration is 2,000 ppm, or 2,000 carbon dioxide molecules per 1 million total air molecules, and the outside concentration is 420 ppm, then 4% of every breath a person takes in a room will consist of air that's been in somebody's lungs. For airborne viruses, we want to keep that rebreathed fraction and carbon dioxide concentration as low as possible. If we want to use CO2 as a carbon dioxide as a ventilation fluid, we need to make sure that there are no non-human sources that are going to impact the concentration, such as indoor combustion or vehicles idling outside indoor air tanks. In addition, it's also important to note that CO2 is only a proxy for human emissions and does not account for many other things that impact our indoor air quality. If we want to use consumer grade CO2 monitors, we need to make sure that we understand they have limitations. Monitors using NDIR sensors can have errors non-NDIR sensors can have errors depending on their calibration chemical. Although NDIR sensors report values to 3 significant digits, they're only accurate to about 50 ppm. Finally, all of these sensors can drift over time. So it's important that we measure the difference between indoor and outdoor CO2 concentrations, as that gives us the most accurate and reliable data that we can use. To use CO2 sensors to check ventilation, we need to place the sensor outside for 5 minutes. Make sure the room to be measured is occupied with normal occupants and use patterns, but has no non-human CO2 sources. Locate the sensor in the middle of the room and log the data for a full day. Ventilation changes dependent upon the windows, operation, season, weather, and HVAC operation. So we need to repeat this measurement on a regular schedule. Carbon dioxide concentrations build up in a classroom over time. This is why you can't just take one measurement at one point during the day. Rather, it needs to be logged for the entire day. In this case, you can see when kids entered a room, went out for recess, and the peak concentration, all of which would give very different single point readings. The data of interest for us here is the highest average value over approximately 15 minutes. In this case, it's about 1200 ppm or about 800 ppm above the outside concentration. The power of the CO2 monitor is that in this portable classroom, the CO2 concentration was about 2100 ppm the day before the teacher was given a CO2 monitor. They were able to actively open windows and doors to reduce the CO2 concentration by 900 ppm. ASHRAE is the North American Standard Organization for Operating and Building operating buildings, and it provides standard values that classrooms should be ventilated at in pre-pandemic times. In this case, ASHRAE recommends that ventilation for classrooms with 5 to 8-year-old that is typically would result in CO2 concentrations that are about 550 ppm above outside concentrations, or 970 ppm. This air change rate is roughly about 2.6 for an average size classroom. Pre-pandemic studies have shown that most classrooms are not ventilated to these standards and typically have higher CO2 concentrations. Since the pandemic, several organizations have suggested roughly doubling the effective ventilation rate in classrooms to 15 liters per second per person, and this would result in concentrations that are about 400 to 500 ppm above the outside concentrations, or result in effective air change rates of about 5 to 6 per hour. The bottom line is that CO2 concentrations vary with time, room, season, and weather pattern. A single measurement from a few minutes is unlikely to capture the dynamic ranges or give actionable data. High CO2 measurements do not necessarily mean there is a risk, and low CO2 values do not also signify that a space is safe, only that it's safer. Finally, CO2 monitoring of ventilation is but one component of overall risk reduction strategy to move viruses from airs that includes portable air cleaners and HVAC filtration. Thank you. I'll turn it back to David.
So back onto the topic of portable air cleaners. For pandemic purposes, using a portable air cleaner is equivalent to outdoor air. And although Dr. Corsi's talked about the give an example of the sizing, there's some other things to take note of. And some of the lessons that have been learned from both Ontario and other jurisdictions where they've deployed many portable air cleaners into classrooms is that you want to have as large a capacity as possible for the air cleaner, a large clean air delivery rate. Second, focus on the noise as well. You don't want it to interfere with instruction. So they're rated at the highest speed, and that's also the highest noise. So even if you oversize it, you can still slow it down and at least get a lower noise. Third, hold the extras. Avoid ionizers and other technologies and bells and whistles that are going to add in some more cost. Focus on the air delivery. And then prioritize to the naturally ventilated and exhaust only classrooms. You may need 2 or 3 of them for equity with their mechanically ventilated counterparts. And so for more on filtration and making your own air cleaner, I'll turn it over to Jim.
Okay, thank you. And am I showing here? Got David. Is everybody hearing me?
Yeah, you're good to go, Jim.
Okay, great. So let's go to the next slide. ASHRAE is, the recommendation is for MERV 13 filters or the highest possible compatible with HVAC systems. Here's a little bit of an idea of where that fits in. Two charts, one efficiency on particles 1 to 3 microns, the other one particles 0.3 to 1 micron. You'll see that MERV 13 filters in both categories are substantially better than the other filters. So that's why the recommendation is what it is. Next slide, please. Okay, so here's the problem, availability. You know, it's great to say MERV 13 was what we needed. It was 5% of the market. All of a sudden in 2020, the demand went to 40% of the market. You couldn't get MERV 13 filters. I just talked to a major manufacturer last week. They have upped their capacity. That is not going to be as much of a problem this year. That's not an excuse that school districts and universities can use. Cost, it's definitely more expensive, but thankfully the MERV 13 prices are stable. And you have to consider true cost, which is the filters, the cost of the filters versus the risk involved. So it's a very, very low relative cost. And then compatibility of equipment. And again, the concerns are that the increased resistance of the MERV 13 filters are going to tax the older HVAC systems. But if you look at it, the next part of the slide, we've got a MERV 10, a MERV 11, and a MERV 13. All three of these are relatively close in resistance. So if they're going with filters that are pleated filters, well made, that is not as much of a concern as it has been made out to be. Plus, the MERV 13 gets dirty faster. You're going to have to change it out faster, but I think that's what you're trying to do with the filter anyhow. It's a good thing that the filter is getting dirty. Some school districts have gone to MERV 11, which is perfectly acceptable. It's a good alternative. They're worried about their equipment. And MERV 11 is certainly better than a MERV 8 or a MERV 10. And then right now what we're seeing is that schools are either all in, they're buying MERV 13 for every building, or they're all out. They're buying no MERV 13 at all. And my position would be that every school district has buildings that have plenty of capacity in their units. They should be spending the money on MERV 13 filters rather than other things. It's a very small percentage of the overall building budget and a very good investment at this time. Next slide, please. Next slide. Okay. So most of you have probably heard of the Corsi-Rosenthal box. It's a low cost, do it yourself, easy to assemble and effective air cleaner. The picture on your left is one that's fully built. It has a tape shroud. David has done some great work on making sure that we know exactly how much of a shroud is needed. And then the diagram on the right, volunteer did this and put a nice shroud on top. It's very simple to make. Next slide, please. So here's some of the advantages of this Corsi-Rosenthal box. If you have the money, I would definitely recommend buying a good high quality HEPA air purifier. But if you don't have the money, this is a great alternative. The supplies are very easy to find. All you need are 4 or 5 MERV 13 filters, a box fan, and tape. It's inexpensive, costs less than $100 to make it. Simple construction. And I'm really serious about this. If you can seal a box, you can make a Corsi-Rosenthal box air cleaner, and just really that simple. It's powerful. By using this box design, you avoid the resistance of the filters. You also create negative pressure inside the box as the air is drawn out from the fan. So it's 500 feet per minute, 24 inches from the fan. You're not really going to get the same thing even from good HEPA air purifiers. It's efficient. If you look at like 2.5 microns, 94% efficient, 5 microns, 95% efficient. These are particles in the target range that we're looking at, even down to 0.3 microns, 58%. And by the way, you'll get this question, and Lindsay referred to this earlier, where people think that filters don't capture particles lower than 0.3 microns. And that's absolutely incorrect. Filters include HEPA filters, MERV 13 filters. They all get more efficient because of the way that filtration works. They get more efficient on these smaller sized particles. It's safe. UL has studied this, and they found that it actually meets all the limits for safety. We had a lot of concerns early on about whether or not motors would overheat or we'd have strain on the motor. And even with one filter on a box fan, it's within the prescribed limits. And it's relatively quiet. It's 51 decibels at 6 feet. And finally, next slide, please. It's scalable. It is the type of thing that any school could do. It's a type of thing that could be a project. You could have 10-year-olds doing a science project and making something that would make their classrooms safer and reduce any viral count that's in the classroom. It's a great way to have people learn and feel like they're helping with COVID. And with that, I will turn it over to Kim. Thank you.
Great, thank you. That was really, really informative, and hopefully people want to learn more about it because there are alternatives that are very excellent. So thank you so much. All right, so now the other angle on how to keep kids safe, we hope will happen soon. And we have an expert, my colleague Chip Schooley, who's going to talk about vaccines. So Chip.
Thanks very much, Kim. I'm going to be relatively brief today because this is mainly a discussion about air. But I want to also point out, as we'll be discussing this, that vaccines also keep the air clean. In terms of the why we should be vaccinating people in school.
Can you go into?
Yep. Sorry, I will do that.
No, it's okay.
Okay. Let's. What are the reasons to vaccinate people in school? The primary reason to use any vaccine is to try to prevent disease. And those who are vaccinated. It's important for faculty and staff, and people have often said, well, why should we vaccinate the students? They'll be fine. In fact, as we've already heard, they're not always fine. They get sick as well. So we recommend vaccination for all the people who are in the schools for their own personal benefit. We also recommend vaccination to help decrease the transmission of the pathogen, both in real time by reducing the levels of pathogen shedding in those who are infected despite being vaccinated, to reduce the number of people who are infected, and to limit the evolution of more dangerous and more transmissible variants. So we're also investing in the future by vaccinating now. Everyone has seen these clinical trials. The only point I want to make in the original clinical trials is they were not done with shortcuts. They were done extremely carefully and included 75 to 80,000 people. But since that time, we've now seen over 180 million people receiving these mRNA vaccines, followed very closely through the CDC's VA-ERS system. And there've been very little in the way of surprises since that time in terms of safety. The efficacy of these vaccines continues to be extremely high in terms of preventing disease and preventing death. And you can see that not just in the statistics, but just in looking at correlative data about where the disease is now exploding. It's exploding in parts of the US where vaccine rates have been lowest. Now, we've heard a lot about breakthrough cases, and I think it's an important point to discuss for two reasons. First is breakthrough cases are defined as people who get infected despite being vaccinated. These people aren't always cases because case means that someone is actually having symptoms. These are people who happen to be infected and may be shedding virus. As you can see in this this graphic, looking at the data from California, vaccines are much more effective in terms of preventing people from becoming symptomatic or dying. This is the protection rate, 95 to 100%. But less effective in terms of preventing them from becoming infected without symptoms or mildly ill. And this is true of any vaccine. They are much better at preventing disease than preventing transient infection and shedding. We already know from the data that Kim showed you, that Kim Prather showed you, that although early on the transmission rates may be quite high, or the shedding rates may be quite high in vaccinated in green or unvaccinated people in red, that the area under the curve is much, in terms of how much virus is shed, is much lower in those who are vaccinated because the immune system that has been teased by the prior vaccination kicks in very quickly and drives down the viral load. So this actually helps clean the air as well. You're doing this for yourself and for those around you. Side effects are primarily those of sore arms. We see that in adults, we see that in kids. And in some people, for a couple of days, mild flu-like symptoms that go away, sometimes requiring some Tylenol, but most of the time being self-limiting. There are very rare side effects that are seen. The one that has been talked about most in adolescents has been mainly in adolescent boys, and that is transient inflammation of the heart muscle or myocarditis that occurs in about 50 per million vaccinated kids. It lasts usually a day or two. It is occasionally associated with hospitalization, but really generally doesn't require medical intervention and is reversible. We see these same kinds of side effects, but to a greater extent in terms of cardiac effects in children who get the full disease. Finally, should everyone wear masks in school? I think from what you've heard already, the answer is yes. This is one more layer of the Swiss cheese that decreases the amount of shedding in the classroom and decreases your risk of picking it up. Now, one thing that I think is also important for us to know is that everything we talk about is situational. And when the situation gets better, we as scientists will always reassess the conditions and can always then make new recommendations. So a lot of the consternation people have been having about going back to masking, this is not forever. This is for in the midst of places that are having surges. And this is one of the ways to help us get through this. So it's very important to think about where you are, what's going on, and to do everything we can to help us get through this difficult period as we're getting people back to school. I'll stop there and turn this now back to Dr. Prather.
Thank you, Dr. Schooley. That was excellent. I think that was a winner statement. The vaccines also keep the air clean. I hadn't thought of that, but it is so true. Thank you for that. And so now I'm back on stage for my last little discussion with a team of people because I basically helped open San Diego Unified School District with a number of other experts, including Dr. Schooley and Dr. Terrace, who will comment after I get through sort of the overview. It is possible. I mean, this was done last spring, and it was pre-Delta. So everything is harder now just because there's just can be so much more virus in the air. But I think a lot of people, when they hear us concerned about masks, people will say, oh, they take away our freedom. They let kids go back to school now in this mess. It's the only way kids should be going back to school. But there's other things we can do, and that's related to the layers. And so we required masks indoors. They required masks indoors at all times. You've heard about ventilation with CO2 measurements. There's some people say, oh, ventilation is expensive. Opening doors and windows and knowing to ask if you're bringing in fresh air through the HVAC system is free, right? So it's just the knowledge and the awareness, and that's what I hope we're giving to you today. You've heard about standalone HEPA filters, which just brings down the virus levels in the air, all aerosols. In fact, as we get into we're going to talk about this a little bit, but wildfire smoke. What do? We can't open the windows because we bring in all the smoke. This was a problem last year. These HEPA filters will take out air pollution, wildfires. I mean, they're a great investment to help clean the air in kids' schools post-COVID when we get there. So, we checked that with particle sensors. And so this is just some ideas. And again, I'm working on a paper to get this out to the public. But basically, this is the pad they created. I just told them, you better clean the air. And they did it. And then some, they ordered 10,000 HEPA filters, put them in every room. But you don't always have to put them in every room. If you have rooms that have, as was mentioned, good ventilation, then you can, you have to figure it out, right? And so that's a pretty simple thing to do. This is the indoor purple air sensor. This is a AirNet sensor for looking at CO2 levels. This is the panel. They would send me the data. This is the particle data in each classroom to see, and they could see when it went high. And then one time, they went and saw that the teacher had said it was too noisy at that time, so I turned it off. Turned it back on, the levels go back down. You can actually really clean the air. They also, I have to say that one of the most important things for those of you dealing with this in schools is that you have to be transparent. You have to tell the public what you're doing to clean the air. Don't just say, oh, we've got this. Yes, we're following CDC guidance. That's just not enough to calm people down. So people actually enjoyed, this is a green spotlight. This actually has a sensor on it to show you the CO2 is in the green zone. It just gives peace of mind. So you don't have to, because it's invisible, so you can't really be sure what you're breathing. And so again, just work with the public because everybody is nervous at this time. So the other thing is, sort of stepping through to the other things that were added in. There was a number of questions about, the riskiest time is lunch. And we'll talk more about this, I'm sure, through the day. The dream would be kids not talking, I don't know, show a movie outside or something. That speaking and yelling is what starts to release it into the room at higher levels. We had small cohorts and we could have 6 feet distancing. That's going to go away in the fall. As I say, with Delta, that's a concern. So, I'm going to breathe a lot easier for all of your kids and everyone's kids when the vaccine is approved for less than 12. And then the question will become the vaccine policy for everybody. I hope so. Indoor mask mandates right now are critical, as I made the case. I think we've made the case even for the vaccinated. I also helped reopen UC San, or not reopen, we never really completely closed, but we had a huge, and that's a whole nother talk, effort called the Return to Learn effort, and we were successful as a large university. But one of the really important things, and I think schools have to think about this too, is free or cheap testing. And so, these rapid tests, I think are underutilized. So there's all kinds of things that we need to be thinking about, taking on this extra challenge of Delta that we didn't have. But I will tell you, San Diego Unified has over 100,000 kids and they didn't have any outbreaks. And so it is possible, but we live in San Diego. And so we were able to use clean air, get clean air relatively easily. So I just want to quickly mention, and then I'll hand it off. I'll have sort of get you the perspective of Howard, or Dr. Terrace, who led the effort, and a parent who also had to go through the whole thing. But one of the things I just want to point out is that clear guidance has to be given for addressing aerosol inhalation. Plexi was everybody's favorite. It makes people feel good. If it does block people from coughing and sneezing spray on you, which is good. And if kids are too close, it's good. But we also have to be aware that it can trap the aerosols. Just think about putting up a plexiglass barrier and having someone smoking on the other side. It's going to just go right over the top and it can actually get trapped. And that can be problematic. You've already heard about the other things that we need to sort of not focus so much on and think about cleaning the air more than we have. And this idea of ventilation is what they did in 1918 in schools. Dr. Corsi showed the same figure. They had it figured out. They had all the same rules that we're just coming up with now, back then. So I'm going to, now I would like to just sort of ask Dr. Terrace, who is the leader, who is the consultant that works with UC, he's a doctor at UC San Diego, but he was also the person that worked and led the efforts at San Diego Unified. So Dr. Terrace, it would be great if you could just sort of make a few comments about sort of your experience in dealing with this school opening and what you learned that maybe you could share with people, about how you figured out which spaces did you treat all the spaces the same? How did you figure that out? And I think a burning question for many people is, as a person sort of advising people, how hard was it to mandate masks?
Right. Well, I will tell you that the way that we first started is to really explain to people what aerosol transmission was. Dr. Prather had given us the smoke analogy. And I ended up using that in many, many slides as I spoke to school nurses and to school administrative leaders, because people understand that smoke, even if it's invisible and odorless, is something they can imagine. And I just kept saying, imagine we're all breathing smoke, and how are you going to lower that smoke level, even though you can't see it or smell it? And that gave people some perspective. We did purchase a lot of these room air purifiers, and we were dealing with a situation where we didn't have children in the classrooms breathing, and yet we had to estimate how many particles they were going to put in the air and how they were going to get rid of it. Last year it was easy because it was hybrid learning, so we only had 15 kids in a classroom. This year we have 30 kids in a classroom. And Dr. Prather kind of explained to us, and that's why we bought all these purple particulate air monitors and carbon dioxide monitors. She explained to us how we can understand how the air is going to be moved in any one classroom by using these monitors. And using candles, using dry ice, using things that produce particulate. The question was, did we do the same thing in every building? No, because some of our buildings had really very good HVACs that would fit the MERV 13. So those were fine. And we could see they were fine because when we put particles in the air, either with real people or with some of these fake ways, we could see it go down as soon as you turned on the AC. For other buildings that were old or couldn't take MERV 13 filters, or we couldn't purchase any more MERV 13 filters, that's where we bought the HEPAs. We also have some places where there's very, very old buildings, very poor ventilation. We have gymnasiums, and that's where the dry ice really worked. We were able to fill it up with particles and then see how quickly we can reduce that to a very low particulate safe level. The second question was regarding masks. Fortunately, California, the state of California has now mandated masks for all people inside schools. Until then, we were using education to convince our board members of why they should adopt that. And again, using the smoke technique. If you get it at the source, you're not going to have to deal with all this air cleansing because you've prevented the air from becoming filled up in the first place. California, luckily, is the kind of state that just said everyone indoors has to be that. There are exceptions, though. We have a huge number of children who are getting doctor's notes saying they can't wear a mask because of medical reasons. We have found that probably 80% of those are bogus notes. The doctor has never tried a mask on them. They've never tried various different kinds of masks, inserts that have filters that take it away from kids who have sensory defensiveness. They didn't give kids with behavioral or mental health problems a chance to have positive feedback when they keep their mask on. When we take the power out of those doctor's notes, we require a doctor's note, but then you also put the power into the school teacher, the school physical therapist, the school occupational therapist. And you say, before we give you a medical mask exemption, you got to go through our team. We got to work with your child for an hour or two to see how we can get that child to actually wear a mask. Until that process has occurred, that child does not get a mask exemption. And so that has greatly reduced the number of children who aren't wearing masks in our school buses and in our classrooms.
Great. Okay, well, we'll have a quick comment just from a parent. I had a lot of parents actually volunteer to comment on their experience, and we'll hear from Ian Ricksecker now.
Hi, everyone. My name is Ian Ricksecker, and I have 20 years software engineering experience with a specialty in security and risk management. I'm also the father of a 9-year-old in a San Diego Unified Elementary School. Last March, my ex and I faced an impossible dilemma. At home, we have a 3-generation family, and my mother is taking immune suppressant medication. In the first 2 quarters of remote learning, our daughter was doing very well, but we had just had our parent-teacher conference, and her performance had dropped dramatically. When San Diego Unified announced that they were reopening, we were stuck with the choice: risk my mom's life on a bet that school was safe, or keep our daughter remote when that clearly wasn't working for her. And if the worst happened, would our daughter blame herself for killing her Bubba? When I learned that Dr. Prather advocated opening schools, well, I was very critical. Then I studied her recommendations. I studied airborne spread, mitigation, and ventilation. And when I reached out to my principal, thanks to the work that Dr. Prather and Dr. Taras had done, to ask if we had MERV 13 filtration, she was already up to speed. She answered, "No, given the age of our school, there are compatibility issues with installing MERV 13. That said, I have the district HVAC crew out today trying a test to see if they can make it work. We already have 2 HEPA filters in every classroom and 1 in any back room that a student might access. We're planning for 5 air exchanges per hour." I cannot tell you how reassuring that was as a risk management expert, as a security expert, and most importantly, as a parent. Those who would give up essential liberty to purchase a little temporary safety deserve neither liberty nor safety, is oft quoted in opposition of NPIs, including the measures that are advocated in this presentation to ensure school safety. To my daughter, essential liberty is the liberty to attend school with her classmates without worrying that she might infect or kill her Bubba. Thank you, Dr. Prather.
Wow, thank you. I really appreciate you sharing this, and I'm seeing lots of comments flying that you, many parents are thinking and are all feeling the same way. So thank you so much. Okay, so now we are at the point where, let's see, I got to catch up. Since we started late, I'm letting sort of the time go because I think we all want, after all this effort, to have it recorded and everyone else who can watch it can appreciate it. I don't really want to cut people off and lose all the information that people have put towards getting this done. We're at the point where we could take Q&A, or we could quickly sort of jump into session 2, since we are pretty far behind at this point with the late start. I guess I'm thinking maybe we'll just jump into session 2. We tried to do it all in 2 hours, and we're just going to have to deal with the questions maybe offline or some other way, because there's a lot of them. And so I don't know, Joaquin, do you think just move into session 2 at this point? Is that what the
I think that's good. And then all the questions could relate to all the panels.
Yeah, exactly. Okay, yeah. Great. Thank you.
Yep. So, all right, we could get started here with session 2. And thank you everyone for being here. If you're watching this live or you want to share with other people, you can use the same link after this is done in order to view it again or to share it. So we're starting session 2 now, which is with Dr. Maria Mayorga. And this is on modeling spread of COVID-19, Delta transmission in schools. The floor is yours, Dr. Mayorga.
Thank you. I'm going to try to share my screen in presentation mode. Let's see how that works. Can you all see this?
Not
yet.
Okay. Now?
Okay. Yep. It's
great.
Good now.
Thank you. So I'm Maria Mayorga. I'm a professor of industrial and systems engineering at North Carolina State University. I have a 12-year-old and an 8-year-old, so a middle schooler and an elementary school child. And this is work that's done by a collaborative team of researchers from UNC Chapel Hill, NC State, and Georgia Tech, and East Carolina University. So we've been developing models, simulation models to inform local decision-making for COVID-19. And recently, as part of the team that's been reaching out to the local health departments, they asked a very specific question about wanting to know what the impact would be of having masking policies in the schools. So our goal was to come up with a model to estimate the proportion of susceptible students that would become infected throughout the semester, depending on different types of policies that the school could implement, but also different incoming protection levels for those students. So we made a simple model to answer this question for a hypothetical school made up of 500 students. And we tried to make this model very conservative because we have been presenting this model to local health departments who might be resistant against implementing mask mandates. And we felt that we wanted to make sure that they understood how bad the problem could be even under these very conservative assumptions. So for example, we assume that only 2 to 3 students begin the year, the start of the semester, with an infection of COVID-19. And some students are, we call it protected, in the sense that they're either vaccinated or they have acquired the infection before. And then we assume that we might have only one external infection coming in. This could be from a birthday party or soccer practice or church or something like this. And we also test testing policies where we would randomly test some proportion of the students using an RT-PCR test, and then those students would isolate with a very high probability. So I just want to make sure that for this group, I talk about our assumptions. We use an R0 or an R naught of 4, which is very conservative for the Delta variant. I think estimates are 5 to 8. And this is because we got some pushback initially for people that mentioned that maybe children aren't spreading the disease as quickly. So we took a very conservative estimate of that. We also assume that masks reduce infectivity by 50%. I saw the talk earlier that said it could be as high as 75, but in this case, we are not sure the quality of the mask and if students are using them correctly. We do assume high compliance with isolation and with a positive test. And we assume a well-mixed environment. Students are not separated into cohorts, so they could be mixing at lunchtime, recess, or sports practices, for example. And in this case, we're just talking about what happens in the school. And for these purposes, we do not assume any reinfection or loss of immunity. So this would be, the best case scenario within the semester, there's no reinfections or loss of immunity. As far as estimating the level of protection, we based these numbers on the fact that for high school students, they're more likely to have gotten the vaccine, for example, than middle school students. And in elementary school, it would only be students who have potentially been infected before, but we can change these numbers. So we assume a higher level of incoming protection for high school students versus elementary school. All right, so I just want to, before giving the results, I just want to introduce you to how to interpret the graphs. And at the end, I'll show you the website where you can get these in more detail. But the x-axis is showing the time. So we start with the beginning of the semester, and then we go 107 days to the end of the semester. And what you're seeing on the y-axis is the percent of the susceptible students, those students that were not previously infected, who become infected throughout the semester. So let's see what would happen depending on the different policies. So there's a lot going on here. So I'm going to walk you through the graphs. We test policies related to masking. So that would be the baseline policy. And then we also add testing. So the top two lines, as you can see, are if there is no masking, is the blue line. And you may be able, and you can see that this looks pretty bad, where you have in the elementary school setting up to over 90% of students that weren't infected before will become infected by the end of the semester. And for high school, that is still high at about 80%. Then you might want to do some randomized testing. So in this case, we look at what if we, instead of masking, asked 50% of the students to test weekly randomly. And you see that you could have an impact based on that, but it's nowhere near the impact that you could have if you introduce masking. So if you introduce masking, the red line is mask alone. And you can see that you bring down the infections quite a bit to below 50%. And if in addition to that, you introduce testing randomly, then you could bring down the infections to as low as 10%, for example, in the high school case. So this kind of shows you that the layered interventions work. Now we're focusing in specifically into the middle school. After only 60 days, you have that 80% of the students would be infected that with no masking and no testing. If we had testing but no masking, we could get down to 60% of students. If we did just masking, we could get down to 15%. But if we did masking and testing, we could reduce that further to 10%. And this does not include some of the interventions you all have discussed today, like the air filters and other things like that. So as you can see, in terms of going back to our hypothetical school, this graphic just shows the number of students who are in the number of new infections over time, and that masking, even without testing, is quite effective. But if you can do both interventions, that would be best. So what does this all mean? As we all have been discussing, Delta is very infectious, and since kids under 12 are not eligible for vaccines, they remain unprotected. And without mask, it's possible that 90% of susceptible students would become infected by the end of the semester if the incoming protection is 30%, though I think it might be even lower in some areas for elementary school. But mask and testing in combination can prevent many of these infections. And it could be even higher if we assume higher quality mask and well-fitting mask and other filtration systems like you all have been talking about. So I think what our team has been saying now is mask up or go virtual. I think that seems to be like what is happening, because in many of the schools that have opened up, they have had to close or go virtual within the first few days. So I think that these numbers are quite conservative. And as someone earlier spoke about, virtual is not a great alternative for our children. So if we want to keep the kids in school, we have to require masks. And just want to make sure to mention that we did not consider many of the other effects of kids missing school and the potential infections that could happen outside of the school. So we're working on the model right now to estimate the community level impact of masking within schools as well. And if you want more information, I'm showing here the website, our email address, and there's a preprint of our article at this address here.
Great, thank you so much, Dr. Mayorga. And that was incredibly important information for everyone, so thank you. Next up, we have Dr. Jorge Caballero, and this presentation is on data-driven impacts of COVID-19, Delta risk to kids. You have the floor, Dr. Caballero.
Okay. Thank you. Thank you very much. Of course, now we have the technical difficulties that we were trying to fix earlier.
Are you trying to share?
Yeah, I'm trying to share. I think you should be able to see my screen at this point.
Yeah, you got it. Thank you.
Great. So thank you very much for having me. Just a little bit more background about myself. So one of the things that I've been doing over the last 16 months is actually working with federal, state, and local response teams to help them either gather data or analyze data to help them make smarter policy decisions. And as a parent myself of a toddler, the issue or the question of how do we keep kids safe in schools has really hit home. One of the things that I want to point out is really just to take the baton from the earlier speakers and point out that several schools have these sort of dashboards. Not all parents are entirely aware that these dashboards exist, but this is an example of a dashboard for the LA Unified School District. And we can see a few things that we've already talked about, like the student staff case rate, the community case rate, the broader LA County case rate. And the reason this is important is because we were just earlier talking about some of the modeling and some of the assumptions that are that go into that modeling. And it's important to recognize that Delta really has changed things in very significant ways. This particular school, I've been tracking what's been going on in LAUSD specifically over the last few days. LAUSD started on Monday. They have a baseline rate that they calculated. So all schools started with 0 active cases in both of these boxes here. And since Monday, so yesterday, this particular school had 2 cases. Today they have 9. Across the LA Unified School District, there were 0 to start with on Monday. 70 yesterday, and 363 as of today. So that just gives you a sense for how quickly the Delta variant comes into the picture when it comes to schools. And one of the reasons why we're seeing that is that Delta variant replicates very, very quickly. I'm sure we've all heard the headlines about Delta variant having 1,000 times more viral load. Well, what does that mean? That means that that at the point at which you can actually detect the virus in a particular sample, the person is already more likely to be infectious. And so when we talk about Delta variant and when we talk about testing, the important take home point for parents is that the tests are not going to be perfect, and this is why we need masking, and we need more. We actually need vaccinations as well, because there's a period of time between the time that the person tests positive that the person is already infectious. And for Delta variant, that can be between 18 and 72 hours, depending on how far we are from the testing. So what we see is exactly what we're seeing in LA Unified School District already. These numbers are going to keep going up, not just for this school, but for all schools. And as much as we'd like to think that that the high vaccination rate states are going to be safe from what we're hearing about in Mississippi and Alabama, the fact of the matter is that when you look at the underlying data, the problem is that there is just no vaccination for kids below 12. And what we're finding is that that particular age range is where we're seeing the biggest increase in both cases and hospitalizations. And so that goes back to an earlier part of the talk, where we talk about hospital capacity. And if we look across the country, nationally, we are already pushing all-time highs in terms of the number of children in hospitals across the United States. We are virtually certain to break an all-time record within the next week to 2 weeks across the U.S. There is no state that doesn't have this particular shape of the curve. Now, on a day-to-day basis, we are, and this is the part that's really striking from a data standpoint, we've never admitted as many children to hospitals in such a short period of time. You can see, dating back to when we started collecting these data at the federal level, at the national level, in early August, the curve has never gone up that quickly in that short amount of time. And back to the point of this being I personally dislike the pandemic of the unvaccinated term. I think it's the pandemic of the innocent, because we have 75 million children in this country that are exposed. Only a fraction of them are actually fully vaccinated. So what we see is that reflected. There is no state that's safe at the moment. We need to improve we need to improve our testing protocols. We also need to improve our mask guidance and our ventilation for children. I will reiterate the importance of really pressing and considering the value or the ability to do more outdoor instruction or outdoor activities, because that is really the only those are the primary ways by which we're going to keep kids safe until we have vaccinations for all of them. Bigger picture, it's not just about the immediate case of COVID-19. there's this secondary effect of an inflammatory disorder called multi-system inflammatory syndrome for children. We can expect a similar sort of secondary wave of this ICU level syndrome within the next few weeks, as we get about 3 to 4 weeks away from these initial states that are reporting large cases. And then taking a further step back, we can't ignore the overwhelming data at this point that shows that long COVID, meaning just chronic lingering symptoms, is something that children actually deal with anywhere between, on a very, very conservative basis, about 1 in 100 children. More realistically, about 1 in 25 children will have lingering symptoms of either fatigue, chronic pain of sort of unfamiliar and vague nature, and difficulty focusing on a day-to-day basis that will linger beyond 4 weeks, and that data is getting stronger and stronger by the week. And so we have to consider, as a parent myself, I consider the immediate effect, the secondary effect of potentially risking a hospitalization later on, and then even thinking bigger picture as we think beyond the immediate course of COVID. And so as we think about what we can do, the thing that I hope that everyone watching this can take away is that it's important. These are policy decisions. These are policy choices, and to the extent that we have the ability to do something about it, we can always call our state legislators. We can call our congressional representatives. We can call our U.S. senators and press them to prioritize the health and safety of children. And as long as there's public pressure on making this a priority, we can improve masking, we can improve ventilation, and we can improve vaccinations for children. So I'll leave it there and pass the baton to the next speaker.
And thank you so much, Dr. Caballero. And you said pandemic of the innocent. I think those words couldn't be any more true. So thank you again. Next up, we have Dr. Julio Rickman on state policies to prevent COVID-19 among children. Dr. Rickman, if you're ready.
Thank you so much for having me. I'm Julia Reifman. I'm an assistant professor at Boston University, and I direct the COVID-19 U.S. State Policy Database, and I'll be presenting on state policies to prevent COVID-19 among children. This figure summarizes hospital admissions among children in the United States between August 1st of 2020 and now. And you can see that we're experiencing record levels of hospital admissions among children, and that they're rising at a record pace. They are at more than 2,000 per week at this point. And we do see that the worst case scenarios that Dr. Mayorga described are playing out. This is the state of Alabama, which is experiencing that worst case scenario. They started school around here. It's been just 2 weeks, and I've never seen a curve that looks like this. And this is what we face with schools opening right now. I also agree with Dr. Caballero that this is a policy choice. This record rise in child hospitalizations is not inevitable. And it's especially sad because it's just months before children become eligible for vaccines that reduce the severity of COVID-19 and the likelihood of hospitalization. And that makes the urgency of reducing childhood hospitalizations that much more extreme. So my summary of my presentation is that Delta is different and that we should take it very seriously. It's different for children. We're still learning about it, but to the extent that we can see what's happening, it's very concerning. It's especially important to protect kids until they can be vaccinated. And these are CDC data on vaccination rates among children under 12 who can't be vaccinated yet. in the population, among children 12 to 15, and among children 16 to 17, who also continue to have low rates of vaccination as they enter school. So the key actions I'll recommend in this presentation are state indoor mask policies to reduce community transmission. And by state indoor mask policies, I mean masks for everyone, not just for kids, but also masks for kids. Redoubling efforts to vaccinate children 12 to 17 who are eligible for vaccines, and planning for rapid and equitable vaccine delivery for children under 12. We have strong evidence that state community face mask mandates are associated with reduced COVID-19 cases and deaths. These are the strongest two studies that we have on policies, and that's why I present these two studies in particular. Both of these studies compared trends in COVID-19 case growth before states implemented mask mandates relative to states that never implemented mask mandates and their case growth over time. So here, this is all summarized in one figure and one regression, controlling for other policies that changed at the same time. And you can see that both policies actually use different data sets on state policies and took place over different time periods, but they find strikingly similar results, that after states passed mask mandates, there were reductions in cases that actually grew in magnitude over time. With each person whose case is averted, that averts more cases. And people have said, well, what do we know about Delta? Just like we can use treatments that we've learned about earlier in the pandemic, in the case of Delta, we can also use prevention policies that we've learned about earlier in the pandemic with the case of Delta. So you've seen a lot of individual level evidence presented by Drs. Marr and Prather and other presenters in the presentation. And here you can see the policy level evidence that masks are very effective. And to the extent that they are effective, every person whose case is averted prevents 5 to 8 more cases with Delta. And so I would actually expect that we might see an even greater impact of mask policies in the face of the Delta variant. Community transmission is strongly associated with child hospitalizations. So these data are based on Delta. These are the New York Times data on total cases per 100,000, the weekly average for the last week. And I pulled data on child hospitalizations per 100,000 from August 12th. And you can see that there's a strong relationship between what's happening across the state and for total case transmission and what's happening with child hospitalization. And if you can reduce total cases, you can reduce child hospitalization. State mask policies may make some people feel uncomfortable or may not be as enjoyable as not having masks on, but they are better than our other alternatives to reducing COVID. So these are the other policies that we have to reduce COVID. Indoor dining closures, broad business closures, stay-at-home orders, and school closures. And if we have no policy to control COVID, then what we often end up with is the worst, the school closures that reduce education, that keep kids away from each other and from the social benefits of school, and that keep parents home and having a hard time working. And so indoor mask policies are ideal because they reduce transmission in everyone, vaccinated people and unvaccinated people, including all kids under the age of 12. And they have little downside and they prevent policies with worse harms. They're better for our health and for the economy and for education. Not everyone may want to wear masks forever, I think mask mandates for the whole population at all times may reduce COVID most effectively, but there are also policy examples of state mask policies linked to data so that people have a clear on and off point for when they wear masks. And I like this example from Nevada. It's a very simple policy. I've actually copied it here because I know that there are so many local communities working to make policies right now. And the language is very simple. They basically say individuals will wear masks in accordance with CDC guidance, and they link it to the CDC guidance. So if we have a more virulent variant that comes along, something that has a higher death rate, the CDC could change the threshold and it would automatically update this policy. If we have a variant that comes along that takes over that is a lot less severe, great. I hope that happens, and the CDC could change the policy, and the policy would only turn on if if it really became a problem. So I think this is a very smart approach to controlling the pandemic and living with the pandemic. It turns on and off. Policymakers don't need to go back to the drawing board every time. And this helps control the pandemic so it doesn't control us and our schools and our kids. So school mask policies, what do we know about them? The best evidence on state mask policies is from the studies that I showed you. We also have very strong individual level evidence that masks are a key prevention strategy. State indoor mask policies for everyone and not just for kids are most effective for kids and adults, and state and school mask policies are the bare minimum. Masking must be complete to protect people. So it needs to be in all places when people are indoors around each other. And that includes finding safe spaces for kids to be able to have lunch and eat snacks outside or spread out as far as possible from each other. And the discomfort, again, is less harmful than school closures or severe illness in friends or family. So people are worried about children's mental health. And I think the severe illness among their peers and among their family members who may get COVID from them would be much more severe. I also appreciated that the Kaiser Family Foundation found that children found not being allowed to talk in line more onerous than having to wear a mask. And so, I think we can reconsider talking in line, but we should keep mask mandates because they're very important for protecting everyone. Changing policies in response to changing disease is a good thing. Israel reimposed their mask policy in June based on the data they were seeing on Delta. Canada, Alberta recently changed their mask policy and reinstated it. And our CDC scientists recommend that we change our mask policy in the United States. They say universal masking is essential. That means masks for everyone to reduce transmission of the Delta variant. There's also widespread public support for mask mandates. 80% of Americans approved federal, state, and local indoor mask policies based on the most recent data. And these are earlier data suggesting that 69% of American adults supported local mask requirements. So in conclusion, most childhood hospitalizations are preventable and state indoor mask policies for everyone are key. We should deliver vaccines to children 12 to 17 quickly to avoid further overflows of pediatric hospital beds. And we should plan for rapid, equitable vaccine delivery to children under the age of 12. Thank you, and it's my great privilege to pass the microphone to Dr. Teresa Chappell, whose work I greatly admire.
Thank you for that. Hello, everyone. I do have some slides, but I'm also, I think by the time I figure out how to share my screen, my time might be up. So I'll start talking, and if I can get my slides to show up, that'll be great.
Yeah, don't feel totally rushed. I mean, we're just I'd rather capture what everybody has to say. So, if you want, yeah. So
yeah. Okay. Let me see if I can do this then.
Yeah. Take your time. Dr. Prather, you wanted to share a couple slides. Do we want to go ahead and do that, and then we can come back?
That'll block her. So that's not going to help. So I'll do it after. I'm fine.
Okay. Sounds good.
Okay. Is it working?
Not yet.
Okay. I'm going to try one more time, and then if not, I'll just talk.
Yeah, and take your time. No worries.
Can you see the share screen on there?
I pressed the share button, and then when I'm trying to, it's blued out. So it's not really giving me the option after. Okay. Maybe it did just now.
You got it.
Can you see my screen?
Yeah, you got it.
Racial equity in schools, that's showing?
Well, no, it's showing the Zoom. So you'll have to switch what you're sharing.
Open up your PowerPoint.
Yeah.
At the bottom. It's open. Let's see. Maybe it's on the wrong. How about now?
There it is.
Got it.
Great. Okay, great. Hi, everyone. I'm Teresa Chappell. And my background is that I'm a perinatal and pediatric epidemiologist, and I'm a mother of 3 children. I bring my culture, I bring my full self to all the work that I do. And so at the start of the pandemic,
Dr.
I noticed.
Just one thing, if you wanted to make the presentation full screen, because I know it's in presenter mode.
How do I do that?
That might be helpful here.
You can see it okay. Sometimes it's really hard to change it because it's like set up in the screen setting.
Yeah.
Yeah, okay.
Okay. I'm sorry, guys. Wait, let's see.
Oh, wait, there you go. Yeah.
Did that work?
Yeah, yeah. Now I go into presenter. Now go to the, like, click the little thing at the bottom. The little screen thing down there on the bottom. That puts you in slide mode. See it? It's down at the bottom. I'm not.
I think this is fine.
I really shouldn't be so so challenged.
This is fine. We just need your parts of wisdom.
You're okay.
This is fine. Okay.
Yeah, we can see it.
Go for it. Thank you.
Okay, I'm sorry. So at the start of the pandemic, my oldest child was in 2nd grade, and she, once we switched to virtual school, she let out basically a sigh of relief. She was able to learn better. She was calmer. She was happier. She was healthier. And so I started noticing these major changes in my daughter. And being a researcher, the first thing I thought was, is this an anomaly, or is this something that a lot of Black children are experiencing as a result of being able to learn in a loving environment, in an environment free from microaggressions, and an environment free from racism. And so what I did was reach out to a group that I have access to of 10,000 Black parents and asked, were their children experiencing the same thing? What was their experiences with virtual school? And this had been pretty much one of the first times that I had seen anything related to positive responses to people with virtual schools. And what I found was that 45% of the Black parents asked said that if virtual school was to remain an option, and if their jobs would allow for them to continue, that they wanted to keep their children in virtual school. 20% of the parents said, regardless of what's going on with my personal life and my job and my household income, virtual schools is a better place for our children to be, because we could, one, hear what was happening in schools. A lot of the things that the parents really enjoyed was that they were able to listen and hear the way that teachers were interacting with their children. They were able to step in if they felt like there was something happening to their child that was unjust. They were able to also have they were also able to have real-time conversations with their children if they felt like they needed to correct something that was said that may have been historically inaccurate or culturally inaccurate that their children are learning in schools. And so having their children home with them really seemed to offer this new sense of safety and security for Black parents that having our children in in-person school didn't seem to have. One of the things that was talked about often with that group of parents that came out of that work was that the school to prison pipeline was being disrupted. Black children represent 16% of those in public schools, but 31% of school arrest. We talk about how school is, the safest and best place for children to be, but yet prior to the pandemic, Black children were expelled or suspended from school at 3 times higher rates than white children. So when we think about schools, and when we say things like we need to reopen schools, we have to get all children back in schools. Schools are the safest place for children to be. Schools are where learning happens best. I want us to know that there's inequity built into schools, and that the schools that the experience that Black children have in schools does not mirror the experience that white children have in schools. And that these are things we need to take into account when we're really planning for school and what school looks like. A speaker earlier today said that, in general, schools buildings are unhealthy and have bad air quality. And I want to say that in general, schools are different from what Black children experience to what white children experience. So that's one big thing about schools and Black children in the pandemic. But the other piece is that the pandemic really hit Black and brown communities harder than it did other communities. And so when we think about just some of the data that was already shared today and the number of children that are being hospitalized and how that rate of hospitalization in children is increasing dramatically, I want you to think back to studies that were done earlier on in the pandemic that showed that 3 out of every 4 children hospitalized with COVID were either Black or Hispanic. And so we're experiencing a different pandemic. The burden of the pandemic is different for Black and brown children. And then schools are different for Black and brown children. And so yet when we're thinking about bringing all these children back to school, I want us to think about what does that mean in terms of the burden of the pandemic? What does that mean in terms of the places, the policies, the structures that we're sending Black children back into in schools? And is this really the overall best approach for us to be taking for Black and brown children in the midst of a pandemic and in schools? Another piece of data that I think about often is that when we're thinking about children and how well that they actually perform in school, it's not just about are they learning in a safe place? Do they have good quality teachers? Things that also predict how well students do with education and learning are things like social determinants of health. We know that children who are living in financially insecure households do less or do worse in school when compared to those in secure households. So that made me think about what happens for those children who are having the burden of the virus impacting their families even more. So what about Black and brown children who are experiencing more hospitalizations of their families due to COVID? How do we really expect those children to go to school and really survive and thrive in those types of school settings? We talk in general about, the pandemic, and we hear things like children were about 4 months behind at the end of the school year last year. And then when we think about Black children, they were about 6 months behind their period where they would have been in traditional school years. But to me, that doesn't say that the issue here is the fact that we had virtual school or pandemic schooling or hybrid school or however school looked last year. It tells me that there was something happening within Black and brown communities throughout the school year last year that we really need to take into account and that can impact children's learning. And could it have been the data that we've just seen where Black families, Black people were almost 3 times more likely to be hospitalized than white families or white people, that Black people were 2 times more likely to die of COVID than white people. When we look at Native Americans, that number is almost 3.5 times more likely for a Native American person to have been hospitalized and almost 2.5 times more likely for a Native American person to die of COVID during that same time frame. And so what I really want to think about in terms of reopening schools and what that looks like for equity issues is what's the pandemic doing in the community? What's the burden that the children are walking into the schools with in terms of hospitalization, high case rates, deaths of their family members, and then even for them to know that 3 or 4 hospitalizations would be among Black and brown people. These are major concerns that we need to think about in terms of children in schools and their ability to learn and their ability to progress through the rest of this pandemic. That's all I have for you today. Thank you.
Dr. Chappell, thank you so much. That was incredibly powerful. And, what you said really resonated. Burden of the pandemic are different for Black and brown children. And so thank you so much for getting that message out there and for being here with us today. I want to hand it over to Dr. Prather to share.
To try and get it right. Well, first I just want to say, I can't believe it. No, I've got a random tweet that said that I didn't share my slides during the school. This is exhaustion. I guess I can't hide it completely. I really apologize. They weren't that exciting as slides, but I just want to show you two really fast while we get the panel. Everybody's on the panel lined up. So I'm sharing now, am I? No.
Not yet.
I'm testing you.
Yeah, good.
No one,
all right.
No one told me. I cannot believe it.
Working out. Yeah, I think someone shared that you didn't have a slide, but yeah, glad you have it up
I
now.
sent it to the group. Okay. Yeah, so sorry about that. But this, I don't want to take up too much time. First, before I do this, I just want to also mention to Dr. Chappell, that was phenomenal. And I want to make a point that I was the one that had said that, you know, if we clean the air, you know, it's important. But I made the case to the Biden Health Equity Task Force too for COVID-19, in that I feel like if we invest, like the people, as you say, people of color were really hit hardest. And one of the theories, or a lot of people's theories, is that part of that was that they've been breathing some of the worst air quality for so long that they're, you know, they weren't able to handle it as well, or, you know, that's one piece of it. So that's another reason why I think we need to pay attention to indoor air quality, so everyone gets to breathe good indoor air, because that's where they spend most of their time. So anyway, I just want to mention that I did put a plug in that the benefits of this extend well beyond just this pandemic. So just really quick, I'm just going to show this because I don't want to lose any time, and we'll pay for those of you who want to share, and we'll do that for the recording. Joaquin will paste this in to my slides so I don't look like a crazy person. But anyway, this is just what I showed. This is the purple air, the particle counter. This is the CO2 sensor. I have one here. We all kind of have these that we take with us places to see if their air is fresh. So this was talked about. These are the different readouts that we can check different classrooms. And this was just the information that I wanted to make the point. SD Unified went to a lot of work to kind of tell parents in easily accessible information what they did to make the air clean. I won't go into any more, but this is just the only one I want to show about plexiglass. This shows really clearly that how it can get trapped. The air can get trapped down close in the breathing zone. And the rest of it, I guess I said, but those pictures I thought were important, but we'll paste it in so it will get captured in the final version. So thanks for your patience, and I apologize.
All right, and thank you, Dr. Prather, and glad we were able to get your slides in there for everyone. So we're going to move into our Q&A part of this. If you've been asking questions earlier in the chat, and also for the panelists who have been here, and for our speakers, and to be able to ask other speakers questions, we're going to get into that. So if you would like to ask a question, please go ahead and raise your hand, and we'll get this going.
I think we can just, if you want, I think people were sort of voting to just keep going. Sort of, we'll deal with the questions, the big ones. You can address a lot in the panel that you're going to do.
Okay.
And so then we condense things a little bit because we're running so far over. So I saw a lot of notes in the YouTube saying keep going, keep going. So we'll do Q&A. We'll blend it in with the panel. Thank you.
All right, perfect. Okay, sounds good. All right, so we're going to get the panel started then. I'm just going to quickly share who is all on the panel, and then we'll have everyone share, a minute about their experience with schools and Delta, and then we'll get into some of the questions here. So I'm Joaquin Beltran. I'm the creator of Speak Up America, and I'll be helping to moderate the panel. On the panel, we have Whitney Antrim, who's a trustee at Coronado Unified School District, and an attorney specializing in education law at the Erickson firm. We also have Dr. Carolyn Canusio, who's an epidemiologist who studies school outbreaks and runs contact tracing efforts. Additionally, we have Dr. Lisa Delano Wood, who's a clinical neuropsychologist at UC San Diego, and co-founded Californians for Safe Schools. We have Dr. Andrew Goldstein, a medical doctor, grassroots political organizer, and primary care doctor. We have Dr. Alex Huffman at the University of Denver, aerosol scientist and concerned parent. We have Dr. Elizabeth Jacobs from Arizona, epidemiologist from Tucson, and who Help Start, Right to Safe Schools, AZ. We also have Mary Germanis Saba, political economist and organizer with Mass Coalition for Health Equity.org. And finally, we have Dr. Lucky Tran, who's a scientist, science and public health communicator, activist, organizer with March for Science. So welcome to everyone. Please go for it. We'll start with Whitney. Please take a minute and share your current experience with Delta in schools.
Thank you so much, Joaquin. I am here today as an attorney and as a trustee, so providing a lens of governance, meaning practically, what can a school board do and how can parents and community members advocate to get these implements into our schools during this rise of Delta? And then as an education attorney, what are our rights and what can we be looking at, again, practically? What do we do, those of us that don't know the science behind this, but want to make a difference in our schools?
Fantastic. So good to have you here. Okay, and then let's hand it over to Dr. Carolyn Canusio.
Hi, I'm an associate professor at the University of Pennsylvania and trained as an epidemiologist. Throughout the pandemic, I've been running contact tracing efforts and have been consulting to schools and investigating outbreaks that have occurred in school settings and in childcare settings. And I'm here to just remind all of us to lead with empathy, plan for when cases occur so that they don't become outbreaks, and to have our plan B in place if schools have to go online again this year.
Thank you so much, and lead with empathy. I think that's incredibly important, so thank you. Next, we have Dr. Lisa Delano Wood. Floor is yours. Okay, if Dr. Delano Wood isn't available, we'll go over to Dr. Andrew Goldstein. Please.
Hi, everyone. My name is Andrew Goldstein. I'm a primary care doctor and political organizer. And my experience in the pandemic has been extreme outrage as we dragged our feet in the initial days of the pandemic around things like stay-home orders and scaling up contact tracing and mask mandates. And then through the pandemic, have for the last 9 months or so been involved in organizing to end global vaccine apartheid. And that's been part of a coalition of organizations in the US. And most of all, I'm here though, because I've personally experienced feeling politically powerless. And ever since feeling a post-Trump call to political action, have just dived into all the things that we can do and become more fluent in the political toolkit and gotten over my own hesitations and discomforts. And I think all of us have a lot more power than we realize. And I'm here to be able to talk about how people power can get us the policies that we need and deserve.
Absolutely, and great to have you here, Dr. Goldstein. And Dr. Alice Huffman, please.
Hi, great to be with you. So I'm Dr. Alex Huffman. I'm an associate professor in the chemistry department at the University of Denver. For nearly 20 years or so, I've been studying aerosols and biological aerosols in both indoor and outdoor environments. But for the last 18 months, I've been putting a huge amount of my time into doing research and educating widely on the topics of airborne spread of COVID. In part by curating openly available resources on COVID transmission and prevention. You can find it in my pinned tweet on Twitter, if anybody wants to put that in a live YouTube chat. But importantly, I'm also the father of 3 young unvaccinated children in our local school system. And so I've been advocating there and even doing CO2 monitoring some of the school and my university in various places. So thanks.
Yeah, thank you. And thank you for being here. And up next is Dr. Elizabeth Jacobs.
Thank you so much, Joaquin, and it's an honor to be here with all of you. I'm a mom. I've got 2 sons, one of whom was able to return to school yesterday when his school implemented a mask mandate. I'm also one of 5 PIs of the Arizona cohort. And one of the things that really got me moving was some of our data showing that in people who were not hospitalized for COVID, they are still reporting symptoms 2 months post-diagnosis, and that is 77% of our study population in Arizona right now. That's been published by Dr. Bell very recently. So seeing that, you can project out to what the consequences are going to be to my loved ones and neighbors in Arizona. And in addition, our governor has attempted twice now to ban mask mandates. And that is the milieu in which we find ourselves. And it also really propelled me to start Right to Safe Schools Arizona, along with 5 collaborators who all connected over Twitter. And just to give you an example of what the situation is here, we have outbreaks already in at least 22 schools. Our schools started on July 21st for some schools, and one elementary school in Arizona currently has 10% of their students infected with COVID-19. So again, thank you for letting me be here with you today.
Yeah, and so glad you're here, and you're doing incredible work, and that is astonishing 22 schools that have outbreaks since July 21st. So thank you. And next we have Dr. Lucky Tran.
Hi everyone, it's great to be here. I am a biologist, a science and public health communicator, and organizer in several social justice movements, lately March for Science. So I'm based in New York, so it's been a really intense time over the last few years, as one can imagine. And I'm Australian too, so I have been quite outraged seeing the different comparative responses that we've been seeing. So my work over the last year and a half has been really in my day job to get information and really fight this infodemic and confusion about the pandemic, and really get great information out there, both to the media, help train experts how to speak to the media, and really counter all the misinformation. But outside of that, I've really been organizing with March for Science and with lots of collaborations with like-minded groups to make sure that we push public policy in a way that follows science and justice. So I think that's really important. And I really want to say that I really empathize with all the parents and teachers who are on here today. You shouldn't be in this situation where it feels like you're having to choose between your children's education and their health. I think that's, it's an outrage, and it's not okay that leadership has left us in this position and failed us. And it's something that we all on this panel here today, we feel, and it really weighs heavy on all of us. But I am heartened to see so many people participating here today. And I think the more we can connect with like-minded people, the more we can empower each other to do something about it. So let's get organized.
Let's get organized. That's what we're doing here. So thank you so much, Dr. Lucky Tran, for being here. Next up is Mary Germanos.
Hi, everyone. I'm also really delighted to be here with you. And I want to echo some of what Andrew Goldstein said, that my experience of the pandemic has been sort of outrage, but also this feeling of a bit of hope when we can come together as people to kind of combat this sense of powerlessness, which I think we all have as individuals. We actually have a lot more power together than we think. And as some of the successful experiences like the San Diego school system have demonstrated, this is also in our hands. And I co-founded a group of mostly physicians and healthcare workers back in last March to sort of push back in Massachusetts at the governor's lack of action here. And a lot of the work we did was advocating for essentially people who were being most affected by the pandemic, Black and Brown and Indigenous communities and essential, quote unquote, essential workers, to actually have a voice on determining how the policies were being made. And I think that is more relevant than ever right now. And I just really want to emphasize this idea that we have a lot of power together. And this is a really heartening group to be a part of. So thanks so much.
Yeah, thank you. So glad to have you here, Mary. And up next we have, let's go back to Dr. Lisa Delano Wood.
My apologies, I'm juggling a few things today. Yes, I'm Dr. Lisa Delano Wood. I'm an associate professor in the Department of Psychiatry at UC San Diego and a clinical neuropsychologist by training. And I'm primarily a researcher studying Alzheimer's disease and traumatic brain injury, but I'm seeing a lot of patients now coming in with memory concerns due to long COVID. I am a parent of two, one in the San Diego Unified School District and one toddler. And the decisions that I'm faced with keep me up at night, and my husband as well, as we try to make the best decisions that we can. I started San Diegans for Safe Schools. I co-founded that group with other like-minded parents and physicians and scientists here in San Diego County, and we're now nearly 3,000 strong. We're now Californians for Safe Schools, and it's been sort of humbling. You know, we're starting to realize that, as others of you have commented here, there is this sort of problem with disinformation, misinformation, people believing conspiracies that are really toxic and tragic. And the folks on the receiving end, the people that are really taking the brunt are unvaccinated kids. As someone said here, a little bit ago, it's a pandemic of the innocent. And so what I've learned, I've never really been an activist or an advocate, but that there's power in coming together and not giving up. I encourage everyone to attend their county meetings. So we were in a 5-hour meeting yesterday that was so disheartening and so unnerving, while there were 100+ people in that room screaming about tyranny and Nazi Germany and the toxic chemicals being injected and how they're going to refuse all mask mandates, with only 3 of 130 speakers being sort of pro-public health. So we need to be really paying attention. I know we're focusing on the schools, and that's really where my attention has really been focused all year. But it's coming to a lot of our attention that we need to really be moving toward county and state levels. And it's a lot, but I think, again, we have a lot of power in our numbers and really organizing. My last thing I'd like to say is hats off. Thank you, Dr. Prather, and the rest of this panel. These are some of the most compelling, mind-blowing talks I've heard on COVID-19 and transmission. I'm just so grateful that you put this together and that you invited me and so many to attend. So thank you.
Yeah, and we're so grateful that you're here. And so so we'll do a rapid fire question. So it's a yes or no question for everybody here, and then we'll move into more nuanced topics. But the rapid fire question is, should everyone in schools be wearing a mask? So just go for it.
Yes.
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 Yes, 100%.
Yes.
Well-fitting.
Tight and well-fitting.
Everyone should have a mask mandate.
All right. That is great. Okay, so we're very clear here. Everyone should be wearing a mask, right? Okay, amazing. So, all right, so let's go into some of these more nuanced questions. So, schools and with Delta, under what conditions would it be safe for unvaccinated children to go back to school while Delta is spreading in their communities, and to maybe go into more details, what conditions would perhaps you as a parent feel comfortable with? Dr. Delano Wood, and if you want to take this, and then we'll pass it on to Dr. Canusi.
It's complicated, and I don't think it's a one-size-fits-all, and I don't think it's cut and dried. I didn't send my 4th grader back last year. I didn't think she could reliably mask. There were concerns about what was going on. We didn't have enough data. I'm leaning more towards sending her for a number of reasons. We're in a good district that's taking this very seriously and listening to the scientists, and always have, with a panel that they convened a year ago. Do we want them to tighten up some things like outdoor masking and required testing? Yes, and they're considering this. I think we're in a strong district, and the school that she attends has strong leadership that isn't sort of COVID minimizing and is trying to take this as seriously as possible. I don't love that these classes are very full, very crowded. There's not a lot of distancing, but they did put, we have air filtration in there, ventilation, and with really good 94, good masking. I feel good. So I would like to see, I think in an ideal situation, obviously low COVID rates in the community. We don't have that. In fact, case rates in kids are 9 times higher now than they were in San Diego a year ago today. So it's frightening, and we have this newer, more infectious variant. So I think I feel good. I know what class my child is starting in. I know the teacher quite well who is vaccinated. I know that the parents are very serious. 2/3 of them stayed home all year last year. But not a lot of people can say that. And so, but I'd like to see indoor and outdoor masking, distancing at lunches, good filtration, distancing as to the extent possible in the classroom. I think the quarantining rules are really quite lax. I don't think kids really even have to test to come back. They just have to be gone for 10 days. And it's just a lot of that sort of Scouts honor type of thing. That's a little bit concerning. So far, the testing is very, hey, it's here if you want it. It's very voluntary. And I worry about that as well. I think that's sort of problematic. But again, I think it's an individual decision. Now, for my preschooler, I've held her back. I'm continuing to hold her back. She had RSV pneumonia a year ago, and it's just concerning. I have her in what I think is one of the best preschools for COVID mitigation, but they still eat inside at lunch. And so like an ER physician said a couple days ago, masks are just for funsies then, is the quote that she gave, if the kids are eating inside. So it's very complicated. I'd love to hear what others have to say, but I feel like it's a day-to-day decision for me and for many parents.
Quickly, I'll just add to what Dr. Delano Wood said, because I agree with many of the mitigation measures that you mentioned. In addition, I think we need to help our administrators reorient in the era of Delta. We've all now listened to the data today, to very compelling data. And we've seen a pattern throughout the pandemic, I think, of scientists sounding the alarm first, clinicians following, school administrators following then. And so at this critical moment before schools are opening across the country, I think we all need to be in close conversation with school administrators so that they recognize that we can't rely on the experiences from the spring to teach us about how strict we have to be about mitigation measures now. With that said, I think the emphasis needs to be on doubling down on all the prevention strategies we have, not solely emphasizing masks, but thinking about all the tools at our disposal and thinking about using them with the greatest fidelity we can muster. The other thing that I think is very important, and I have 4 children, 2 teenagers and 2 elementary school age children. I think differently for each of those children, as you alluded to, Dr. Wood. Every situation is different. Every school has different resources. Every family has different resources and alternatives available. But every school and every family has to have a plan B and has to be working that plan B and fully developing it so that we can be flexible as we learn more about this new variant and as the pandemic shifts.
Thank you, Dr. Canicio. And you mentioned doubling down on Mask Plus, right? So everything else, using every tool we have available. There are areas with higher vaccination rates, lower vaccination rates. What does it mean? Should people feel comfortable in a higher vaccination rate? I think Dr. Lisa Delano Wood, if you can share, should someone's comfort change in areas with I think you may be muted, Dr. Delano Wood.
I'm trying to figure out if it was my connection or yours. I'm not sure I fully got that question, but
I'm sorry. I just
rates in the community, is that right?
Yeah. Yep.
I think like what we heard today from our experts, we should be we should be putting in all the mitigation strategies we can, no matter really what our community transmission rates look like. And I think what we're seeing with Delta, particularly with some of the vaccines like Pfizer, we're seeing breakthrough cases, and well more than we expected. And even though folks aren't getting as sick, they can transmit this. And I think the data are there. We know it's there. So in some ways, I think it's a little bit semantics, but I do think that certainly the science shows that you have higher rates in and just higher risk when there's more virus in the community. And so that I would just put as many mitigation strategies in place. And if I were in a very low vaccination state, I honestly would think twice about sending my child back.
Yeah, and Dr. Huffman, can you add some more thoughts on this as well, please?
Well, I don't have a whole lot more to add. I think Dr. Delano Wood did a great job there. My decision on whether I would send my children or encourage others to send their children if they have the option not to, in a situation where the vaccination rate is lower, changes. So obviously, the better the vaccination rate, the safer for everyone. But that doesn't really change my recommendation in terms of all these mitigation strategies we've been talking about. And I'll say again that masking in schools, HEPA filters, outdoor eating, all these kind of things are the same across the board, no matter what the vaccination rate, I would say.
Yeah. Thank you. Another question, which is, so for example, if the schools haven't done enough to increase safety and reduce airborne transmission, what can parents do? And how have communities successfully organized to implement things like masking, filtration, ventilation? I want to hand it over to Dr. Lucky Tran. Please go for it.
Hi, thanks. This is a great question, and my colleagues are going to share some specific tips, which are going to be great. But I want the big view. I want everyone to come away from this call knowing three things: one, that you are not alone; two, that we have solutions to fix this; and three, that we can win. So, in terms of the first point, you are not alone. I think there's this myth that individualism is rife. We can't. People don't care. But everything that I see, the survey data, whether you look at Pew or KFF or YouGov, all of these surveys show that the majority of Americans don't think the government is doing enough to protect our communities. Most people support masks, and even a significant amount of Republicans also support masks. So don't think that you're alone here. And as you see on this panel, the majority of public health experts think we should be doing more and want to push for more. So we are all together on this. Don't think you have to share the load by yourself. So connect with people, get organized. Number two, we have the tools, the solutions to fight this. Again, I think there's sort of this bad political messaging that is rife at the moment that, vaccines are the only tool that will help and, there's nothing else we can do. So we might as well do that and hope for the best. There are multiple tools that we have. We've had amazing presentations today on all the different things: masking, ventilation, testing, all of this stuff. I think it's really important. So we have those solutions. So, and I think that's important from an organizing perspective too, because sometimes things can be lightning rods like masks, but there are multiple layers of mitigations that we can pursue, and we should pursue them all, because the more we can get it in place, the more we can protect our kids and our communities. So do follow up on that. And the last thing is really that success and winning is possible. We can make our schools more safer and our communities more safer. I think my experience with the March for Science came into a hostile environment of a government which really did not like science or support science. And even in that environment, we got a lot of things done. We stopped the grad student tax, we made sure science was still funded, and we eventually elected leaders who, put science at the center of their policies. And I think we're starting to see the same despite this difficult environment in terms of public health. So, on the national stage, I think people have really pushed that conversation on masks. And I know the CDC said they changed their guidelines according to new data, but a lot of that was also because of really strong advocacy. So that was a win. And at the more local level, we're seeing, really creative solutions. So for instance, I know in Texas, one school district had a really creative solution of requiring masks after using the dress code, and implementing it in the dress code as a loophole to bypass the ban. So that was a really creative solution. And one thing I like that from an organizing perspective is it creates a decision dilemma, because a lot of people support the dress code for other reasons. So it sort of feels hypocritical to not support that in masks as well. So that's a smart thing. A lot of superintendents I know in Fort Worth, in Dallas, in Houston, other places around the country too, have gone against their governors and ordered mask mandates despite that. So they're a great ally potentially in your area. And then I know a number of states have banned mask mandates, but a number of states have also filed lawsuits against this. And there's some success in places, again, like Texas and Arkansas, who have had some of those mandates suspended. So those are reasons for hope. And generally, I know a lot of that stuff is legal, and I think Whitney and others will talk about more specifically about that. But one other thing I want to say is that we do need to build a grassroots movement, leverage, social media, leverage our communities, and leverage the media to build this momentum. Because the more people we get on board with this cause, the more we visualize it, the more new people you get to help, the more you make it an issue, and the more we can win. So please get organized. And I'll leave you with that quote that it always seems impossible until it's done, from Nelson Mandela. I think, it does seem a difficult environment right now, but look how many people are on this call. Look how many people are presenting today. We have the people to change everything. So, we stand with you, get organized, and I'll hand it to my colleagues.
Thank you so much, Dr. Tran. Absolutely. And you mentioned, states banning mask mandates. Diving deeper into this, we'll pass it to Dr. Jacobs, who is in Arizona and has been working on this. Can you share more of how communities have been successfully able to organize to change this?
I can, and I know we're running short on time, so I'm just going to keep this quick. We organized. I've never done anything like this before in my life. It is just the momentum that has carried us to start making steps and things available in our toolkit that you just click on it. You can find the information you need to contact your elected officials, your school board, whatever you need. It's at Right to Safe Schools AZ. And now I would just like to really talk to the people who are watching this right now and say how much we need you to step up. So somebody just mentioned that a school board meeting had like 100 speakers opposed to masks and 3 supporting it. And that's what's happening because we aren't yet organized. I think a lot of us are thinking, this is obvious, we should have mask mandates, only to find out just before school starts that you don't have one yet. So I am looking out to all the people who are watching this, and I am asking you to help us, please. We need your support, and we need to keep pushing for mask mandates in schools, for filtration systems, and for vaccinations. Thank you.
Yeah, thank you. And also, let's get some. I know Mary has some more thoughts on organizing as well. Please go for it, Mary.
Yeah, thank you so much. And as Dr. Jacobs just pointed out, some people get involved at any moment in organizing. It doesn't have to be something that you've been doing your whole life, which is some of us on this call, have been organizing since we were young. But I guess I just wanted to emphasize the importance of if you feel alone, reaching out and doing a mapping, for example. That's one of the things we're doing here in Massachusetts. For example, think of who are your potential allies on your local city council, which teachers in the schools. Think about the teachers union and what kind of policies they've been advocating for, the local nurses unions that have been very active across the country actually on COVID safety, and really building a coalition inside each at a local level. It looks different everywhere, but the sort of process is the same. And reaching out to each other and to people on this call and kind of making the scientific information, all of these sort of fact sheets that exist and that are being produced actionable and making them available, because I think, it's a sort of 2-step process. There's education. There has been a lot of misinformation about this pandemic. We need to educate ourselves and each other, but then we also need to work together to make those steps meaningful in our communities, and that looks different everywhere. So yeah, I really just want to kind of emphasize that we, again, like I said, we have way more power than we think we do.
Thank you, Mary. And Whitney, what if we have a scenario where someone is told, someone from the school tells a child to take off their mask? What are the, what are parents' rights there?
If someone tells a child to take off their mask, the child, has every right to continue to wear it. It's an interesting question. The child does not have to comply with that request. That is, I can't imagine any context where that would be required. The points that I really wanted to speak to include things like that, where there's confusion about what can someone do and not do. And I want to address the perplexed, distressed parents, like we heard from Dr. Delano Wood, and some ways that a parent or a community member can follow on the tips that Dr. Tran gave us and Mary just gave us as well. So when you want your school to do something, like make sure the teachers don't tell your child that they have to take off their mask. You need to educate your board. You need to know what they can and can't do in terms of governance, and you need to advocate for what you want to see happen. Give it to them in a neat package. I put together a deck of slides with some really specific examples. I'm going to throw it into the YouTube chat, and it breaks down the strategies that I've outlined: educate, advocate, agitate, and then litigate if you have to. And some really specific things, because as a board member, I'm certainly not an expert in this. I've learned so much sitting here today, and I can assure you a vast majority of board members around this country have decision fatigue. They're being attacked by anti-maskers, anti-vaxxers, anti-CRT. It is exhausting. But if you understand what they can and can't do and give them the tools to do it, they want to do the best for kids. I can assure you. So I'm going to pop this in the chat, and it includes my Twitter handle and my personal email. And I'm always happy to brainstorm these things to help you in your community find the right board members. Like Mary said, find the sympathetic people, get them the information they need, understand the abilities that they have, the parameters they have to work in, and empower and enable them to really make those policy changes for the health of our kids based on everything we've learned here today. Thank you so much,
Whitney. And I'm glad we're spending a little bit extra time here on this organizing question, because, you know, what can parents, teachers do next, right? And Dr. Gold, you're a doctor, you're an organizer. Do you have some more practical tips?
Yeah, absolutely. Thank you. So I think many of us aren't fluent with the political toolkit for people power, and we need to think about what that actually looks like. And so many of us are on social media. We've signed petitions. We're doing teach-ins and webinars like this one. Maybe we've called a legislator or other decision maker, signed on to letters. These policy methods of like pressuring politicians work, but they're best when they're on ramps to more escalated action, or when the numbers are so high that the numbers alone are very compelling. So I think most of us are less familiar with lobbying, with canvassing, with visual actions, with bird dogging, with fundraising for political opponents, with strikes. And these are some of the tools that are available to people. And some of them specifically that I've seen talked about for school safety have been, what does non-attendance at schools look like when schools are not safe enough? What does non-attendance at work by parents look like when they have to be home with children? What can teachers do that doesn't actually leave the classroom neglected, but still doesn't comply with the powers that be? And so things like not taking attendance, not marking attendance, but still showing up to teach, that actually has consequences for the school's bottom line. Bird dogging principals, bird dogging school board members. This is a way of going up to them wherever they are in the community and repeatedly asking them questions. What are you doing? What are you going to be doing this week, given that cases are so high? When will there be a mask mandate? And these tools exist for everyone. And I think we just need to look to the role modeling organizations that we've had from many other causes, whether that's ACT UP and AIDS activists, whether that's union organizers, whether that's the grassroots people who stopped ACA repeal. So the toolkit's there, and I would just encourage everyone to work on exploring it and finding communities of action that can support you in doing it. To Lucky's point, we are not alone, and we can definitely use an existing political toolkit. So I would encourage everyone to explore more and to continue to be in touch.
Yeah, absolutely. We are not alone. And you know, the point you're making about asking them, hey, what's your plan? What are you doing? Holding them accountable, you know, making a friend center, I think is incredibly important. So thank you for all your work, Dr. Goldstein. So we're going to switch gears a little bit here and talk about transmission. And this is a really important question that a lot of parents are asking right now. We've seen cases of what they're calling fleeting transmission in Australia. So, what are the risks for children in these settings if they're outside? What are the risks of fleeting transmission? And so let's go to Dr. Huffman.
Sure, thank you. So first of all, I'm not an infectious disease scientist, I'm an aerosol scientist, but I'll give my perspective on that. And this is a rapidly evolving situation. And so I think that there needs to be some grace even in the way we think about this. And there may be some differences even the way we think about this a little bit on the panel. But I think that no question there's worrying cases of outdoor transmission, certainly in crowded outdoor settings like festivals that I frankly would just avoid right now. But even just recently, a couple in Australia where it looks like there may have been possibilities of some children playing on a playground and outside and maybe walking to school. So really, anytime you're close enough to breathe in air influenced from somebody else's breath, you have a chance of being infected. But I still think that outdoors is wildly safer than indoors. So we don't want to miss that point. Indoors, not only do you have the exposure from the aerosol plume that hits you in the face, but you also get that buildup in the room. And so outdoors, if you're far enough away to be outside that breathing zone, the chances are dramatically lower. So if your kids are playing outside and they're really close to each other, then there can be some risk, and you may choose to have your kids wear a mask in that setting. And certainly that can provide benefit. But I also think that from my perspective, there's an importance of being practical here. And this is where the strategy that is not my field comes in. We all need breaks from masks, and getting some fresh air outside without a mask on is really important. The last thing we want to do is push this so hard that we cause fatigue so that people don't wear their masks indoors. We really, really need them to wear them indoors, where it's especially critical. In certain situations outside, I think it can be useful. So some risk outside, yes, much less than indoors. A little distance is helpful. But still outdoors is much lower on my worry list than indoors in certain settings.
Yeah, thank you, Dr. Huffman. And it really speaks to the changing nature of risk with Delta. And so keep those things in mind, like practicing social distancing if outside, are incredibly helpful to reducing that risk. So, in different places, different resources are available. There's a different type of infrastructure that's in place. The weather may affect what precautions can actually be implemented. So what are some solutions in cases where maybe it's raining or maybe ventilation isn't readily available? And Dr. Canusio, if you can speak to that.
Sure. So many people on this call are probably very anxious about kids eating together at lunchtime because of all the evidence that we've seen of transmission while people are eating together. So I want to give people a basic structure for thinking about how to organize life at school and what to advocate for at your own children's schools or at the schools where you work. Outside is better than inside, always. And then if you must eat inside, think about ventilating the indoor space as well as you can, but also having small numbers of people in the largest spaces possible for the shortest period of time possible. So small numbers of people, largest spaces possible, and the shortest period of time possible. So even though we're all operating in very different physical settings, geographies, different levels of resources, those same rules should apply if people must eat together. Now, it's also been the case for many schools that they've structured their school day so that children are in school only for half days, for example, so that they're not eating together. And I think as rates get very high, the more extreme measures may become relevant, i.e. going to hybrid schedules, reducing the number of kids at school or in class in any period of time, or going full remote. So small numbers of people, large spaces, short periods of time.
Yeah, and if you could just follow up here with, in case there's cases or outbreaks, in order to prevent onward transmission, what steps should be taken?
Okay. So recognizing that we're short on time and that this could be a whole semester long course, I want people to know that cases will occur in schools across the country. They will happen even if mitigation measures are in place. So it does not mean that your school failed or that someone tried to dupe you or that people are trying to put children or adults in the school buildings at risk. So given that cases will happen, our whole agenda has to be to identify those cases early and to make sure those cases don't turn into outbreaks. So that means we need to have plans in place for testing. We need to have plans in place for contact tracing. We need to have plans in place for quarantine and isolation. And we have to have plans in place for supporting families that are in quarantine and isolation. So each of those steps, the testing and case identification, the contact tracing, the quarantine and isolation, the support for families in quarantine and isolation, each of those things needs a point person or a committee that has really studied up on how to do these things, because in many parts of the country, your local health department will not be able to have the bandwidth to do that tracing and outbreak investigation for you. And there are those of us who have done a lot of this, who are willing to give some coaching and counsel on how people and institutions can do this. The important thing is that we can't just tell people to isolate or quarantine and then leave them alone. People have so many questions about how to stop transmission even within their households. So that's another part that people have to really study up on. And all of these strategies that we're talking about for schools are connected to what happens in people's households and what happens in the community. So all the best prevention steps have to be taken in all parts of our lives. Yeah. I know that I glossed over a lot there. So if people have follow-up questions, there's going to be a conversation on Twitter, I'm sure too, and all our handles are available online.
Great. Thank you, Dr. Canaccio. And I do want to move to a question from a participant who has a greatly powerful story. But I do want to take an opportunity here. If anyone had any closing thoughts that they wanted to share, please go for it.
I'll say something. I just wanted in my closing thoughts just really emphasize the indoor eating aspect of that. We've talked about several different times, but I just wanted to emphasize it forgive an imperfect analogy, but I think that this kind of brings it home a little bit. Really, this is the same issue for restaurants. Whenever you take your mask off indoors, you have tremendously more aerosols in the room. There are mandates that take care of restaurants in a lot of cases, but we're just not being careful about schools. And so we just need to eat outdoors anytime we can. My imperfect analogy is wearing masks indoor all day, only to take them off to eat indoors together, is a bit, to me, like a class being together in a big pool where everyone holds their bladder for several hours of swimming. But at lunchtime, everybody gets out of the pool into the hot tub for a few minutes where they all pee. So it's great that they weren't exposed to pee for most of the day, but they interact with it a lot in those few minutes. So it's the same as true at lunch. You could breathe a lot of virus in that 10 or 20 minutes that are there that invalidates hours worth of wearing a mask. Now, it's an imperfect analogy. There's a lot going on there. I still want people to wear masks, but the point is we need to treat indoor eating really seriously at school. So, and what Carolyn said a few minutes ago, we have strategies that we can deal with this. Small numbers, be quick, don't talk, ventilate, HEPA, but also give some time to flush out the air before another group comes in. This is a really important point. I've done some modeling on this, and this is one of the cheapest ways that you can really add value to the quality of the airspace by just stagger it by 15 or 30 minutes or an hour if you can to really fresh out that airspace. Thanks.
Yeah, that's great, great suggestion. Does anyone else have any additional closing thoughts?
I'll just add a quick thing. I know we're kind of moving. It's been a long time. Folks have been really patient. I would say rise up, stand up, speak up. Do not fear. Do not fear these folks that are out there threatening and just go to the meetings. You can call in. You can be on video. Write your council members. Go beyond the schools. Many of these districts are waiting for word from above. So go to the county, go to the state, find out who you can write and connect with other like-minded people like you. You're not alone, and you're in the vast, vast majority. So please know that this small, well-funded group of folks that are out there agitating and really threatening the very fabric of our democracy are very, very small. And we see a lot of these people traveling to all these different districts, by the way, and pretending that they're in. But so anyway, rise up, stand up, and really don't be fearful, and get out there as much as you can.
Great, and thank you, Dr. Delano Wood. And Dr. Goldstein.
Yeah, just a few closing thoughts. So one, don't rely on other people. We keep us safe means that we all have to show up. Only you have your own personal actions. No one else can show up for you. Only you have the relationships and communities that you're a part of. Also, passion is energetic. Dedication of time is inspiring. Your personal stake, sharing that with other people, that's compelling. And highlighting the moral stakes for yourself and for society is really powerful. I'd also just add that like nervousness is very real, especially with politics, with public speaking, with meetings, with making personal asks. But honestly, with like, having more support, having practice at it, it goes away. Ditto with just not being as familiar with political tactics and strategies, having more support and practice with it can really, make those discomforts go away. We need to have like unity of issues. This is not just a schools issue. The same forces that are driving unsafe schools are driving unsafe congregate living for people in prisons and shelters. It's driving unsafe work conditions for workers. We need to have a unity of these issues. Solidarity is contagious and these issues are deeply connected. And then just super practically, budget time. Budget your own personal time that you want to dedicate to political work on these topics, and then show up for that time in your calendar. And really practically be in touch with 5 people you know in the next day or 2 about this. Engage 2 existing communities or organizations that you have a relationship with in the next day or 2 about this, and get conversations started.
Yeah, everyone is sharing such great practical tips here. So thank you so much. Before I'm going to hand it over to Ymir and to Dr. Prather as well. But before that, we have one really great participant and who's been doing a lot of amazing work when it comes to long COVID and children. Melissa Lynch, are you there?
I am. Thank you for
Please,
having me.
Go for it. Thank you. Please share your story and please share your question. Thank you.
My story is I am global ambassador for Long COVID Kids. And I'm also lead director for Long COVID Kids USA. I am a mother of a 12-year-old long hauler who is 11 months out, continues with symptoms. And I also helped draw up the administration, the bill that was signed on the 26th, the guidelines for schools, because back then she didn't even have school accommodations. No one knew what long COVID was. And I wanted to ensure that these kids didn't have to worry about their education along with the changes in their health at the same time. My question is a lot of these politicians, school boards are now trying to find loopholes, as they always do, around the accommodations. So how do we go about fighting that? And one thing that I would like to say to keep in mind, that 1 in 15%, 1 in 15, and it can be up to 30% do get long COVID. And it can be asymptomatic. You can show no symptoms, and it can be all the way, they're just now finding out from, hospitalizations can even get long COVID. And just keep that in mind as the pediatric surge is happening with the Delta, that, 1 in 15 can get it, 80% will be female. So we're going to have really a future, with chronic illness on our hands with a whole generation. But thank you for having me on here, and thank you all for your wonderful work. I've learned so much. visit longcovidkids.org. We have an international back to school packet for long COVID. And I'll let y'all answer one of my questions. Thank you so much, Joaquin.
Thank you, Melissa. I'm so glad you were here to share your powerful story and work that you've been doing as well. I think that it's an inspiration for many. And so my heart goes out to you because we've talked before about what your daughter is going through. So thank you again for being here. So anyone on the panel or any of the maybe Whitney is a good person to answer that question, since it talks about parents' rights here. If Whitney, if you can share a little bit, and if anyone else from the panel wants to share, and then we'll transition over to Dr. Lindsay Marr and Dr. Kim Montenegro.
Yes, thank you, Melissa, for sharing your personal story. I'm so sorry for your daughter, and thank you for bringing our attention to this incredibly important issue. Long COVID should qualify as an American with Disabilities Act protection, and protection for children with special needs. And so what we need to do legally is make sure that they are meeting those needs. And I know you worked on the bill with President Biden to set some parameters, but we don't want the kids to get lost in the shuffle. So I think the first thing to notice, I think you're in North Carolina, different state law is different, but equity in education really applies. That term started with children with special needs. And I think that your daughter would qualify as that at this point. So you need to make sure she has an advocate for those services and that she doesn't fall through the cracks. Every state has different guidelines, but that's what I would advise, because she's entitled to a lot more help than she's probably getting.
Thank you, Whitney. And if anyone else had any additional thoughts? Okay, if not, I want to thank everyone on the panel for such an informative, I think it was supposed to be 20 or so minutes. I think we went on nearly 40 here. So really appreciate you being here. Just give a quick thank you to Whitney Antrim, Dr. Carolyn Canusio, Dr. Lisa Delano Wood, Dr. Andrew Goldstein, Dr. Alice Huffman, Dr. Elizabeth Jacobs, Mary Germanis, Dr. Lucky Tran. Thank you all again. And it's my pleasure to hand it over to Dr. Prather and Dr. Lindsay Marr.
Could you let me turn on my video, please? Thank you. Joaquin?
Yeah, you can go for it. Yep, thank you.
Thank you. So let me pick up on what we've been hearing, which is that it's really now action that is needed. And Kim has really organized an incredible meeting, and with lots of people who've given both the science and articulated that there is a tremendous need and opportunity for taking action, that really it is up to us to do things. We have planned now to have a follow-on meeting on this Sunday at 3 p.m. Eastern Time, 12 p.m. Pacific Time. And what we're doing is we're creating project teams to engage in many different aspects that are possible. And if you go to a link, the link is worldhealthnetwork.global/action. So it's just one word, worldhealthnetwork.global/action. You should get a form that you can fill in that will identify a number of different project areas that we can work on. Assembling advocacy groups, working on vaccine hesitancy, mask resources, air ventilation, filtration, working on creating a list of questions for schools and boards, etc., petitions, the legal options, uniting parents and uniting teachers. And those are a list. Kim put much of it together, and it's not necessarily either an exhaustive list or the nature of the opportunities that are available, but it's a beginning of identifying the project. And if you sign up for those projects, we will be in touch with you about setting up meetings in a platform that allows effective collaboration among teams. We have established the World Health Network as an organization that has been involved in letters from over 1,000 scientists around the world and involved in community action locally in multiple places in the US and around the world. And now with the current Delta challenge, there is clearly an increasing awareness that we need to take action. So this is an opportunity for us to follow up on this incredibly outstanding meeting with the science, but to now build the community effort, because the local action is really the essential action that we have to engage in with individual schools, individual classrooms, even individual districts, and so on. We already have within the World Health Network projects on DIY HEPA purifiers, air cleaners. We have project on communication on the challenges of opening schools with the scientific information that we've heard placed into formats that are more accessible. Those projects have already begun, but of course, everything that has to be done needs to be strengthened, and local action is the most important action that we can take. I'm happy to take questions, but I think it is now 3 hours after we started this program, and Kim would like, I'm sure, to have some closing remarks. So please sign up so that we can be in touch with you about the follow-up program, which is going to take place this Sunday at 3 p.m. Eastern Time, 12 p.m. Pacific Time. Thank you very much.
Can you repeat that link, please?
The link is World Health Network, written as one word, worldhealthnetwork.global/action.
It's in the chat.
And it should be in the chat, and it should be in the YouTube feed, and we will be tweeting it so that everyone can come to the program and participate in the next set of activities that will come out of this program. Thank you, Kim. Outstanding, and thank you very much for nucleating this effort.
Well, thank you. And I guess I get the final remarks, but I'm going to go really quickly. For people who know me, they know I usually keep everyone timed to within seconds in their comments. And I didn't do that today for the first time in my life. And I didn't do that because it's all captured now, and thousands of people will continue to watch this and benefit from the information. I learned a ton. I have to pinch myself. This is better than I could have ever dreamt of. I have to say it's one of the good sides of Twitter, because I picked everybody sort of. I obviously knew the Airborne crew, but wow, I just can't, I don't know. It's just, I'm floating. I'm tired, but I'm floating. I learned, I can't even tell you, this is way better than so I'm just so happy and proud to have been part of this. I'm sorry that it went I'm not really sorry. It was a great 3 hours. Every piece was good. So, and it will all go to good use. And we got to keep it going. And so Yanir has helped, with his World Health Network, which is incredible. I want to thank Katie has also helped. I couldn't have done this. And the one I really have to thank, poor Joaquin, we were texting at 2 or 3 in the morning this morning, and he wrote me right back 24/7 since we started. There is no way this would have happened without all of them. So I want to thank them. I want to thank all the participants. I want to thank everyone who's propped us up and kept this going. As I say, I feel it's urgent. I feel better personally than I have in a long time, because we're doing something, not just watching something. We can stop this. We can make it better for everybody. And so I just really I'm glad we're a team, and we just got to keep this energy and motion going, and make it all worthwhile. And don't forget, the virus is in the air. I just have to say that every day I wake up, it's aerosols float and droplets drop, and tell everybody you know that, because 90% of schools still unfortunately do not. So I have to get out that one little message. But thank you so much. And as I say, let's keep it going. And as I say, I thought about breaking it off and having another one, but we will now on Sunday. So let's just keep it going. Thanks so much, everybody.
Bye-bye.
Thanks so much, everyone. You can view the stream if you didn't get a chance to view it live, or if you want to share it with other people. Once the broadcast finishes, it'll be available at the same link. So then you can share that. So thank you again, everyone, for coming. Please be safe.
Joaquin, thank you.
Yes, Joaquin.
Thank you, everybody.
A pleasure working with you on this, Kim. And you've been an amazing organizer. So props to you and an inspiration for many. So
the people make it work. The people make it work. I knew once I had all the people pulled together that it would only be good, and it was great.